Hey everybody, this is your voiceover PowerPoint for shock. Really interesting subject. I love this content. This is, really good ICU, CCU material. We have anaphylactic shock. We're going to do cardiogenic shock, obstructive shock, neurogenic shock, septic shock, hypovolemic shock. I think I got most of them, but let's just continue. So guys, here are your readings. Mainly chapter 66, but we just have different page numbers for all the different types of shock we're going to go over. Again, cardiogenic, hypovolemic, neurogenic, anaphylactic, septic, and obstructive. I've just left multi-organ dysfunction and disseminated intravascular coagulation on here. It's just good to know about, but we really don't get too much into it. So we talk about it bits and pieces within the subjects of shock. So it's just good to have in the back of your mind. So here we go, guys, jumping right into it. What is shock? What happens to our bodies when we're going through a certain type of shock? And as you notice, when we go through all the different types of shock that we just mentioned, it's going to be very, very similar for each type. Yes, they're different in their own ways, but our body's response is going to be very, very similar. So always keep that in your mind with each different type of shock. It's going to kind of be very helpful for you to remember kind of our body's way of responding to shock. So what's going on when we enter whatever shock, whether it's cardiogenic, whether it's hypovolemic, whether it's obstructive shock, we are having a decrease in tissue perfusion, meaning that we have an impaired oxygenation status and we have impaired cellular metabolism going on. Okay, so our supply and demand is off. Okay, remember we talked a little bit about in burns when you breathe in the smoke, okay, that carbon monoxide, and you breathe in that smoke. What is impaired? Both our oxygen delivery and our oxygen consumption, right? They're both impaired. So it's a very similar thought. Don't get it confused with smoke inhalation. That's burns. But that very, very similar thought process of impaired delivery and impaired consumption. So delivery and consumption is impaired. And when that's impaired with oxygenation, it's going to affect our tissues and our metabolism. Okay. So our supply and demand for oxygen is not matching up. Okay. So yes, our bodies are constantly demanding oxygen, and typically normal everyday day-to-day life, we're getting that good supply of oxygen, right? So we're getting the demand. We're getting the demand. Well, we're getting the supply, right, for our demand. So in shock, we're not getting that supply that we're demanding, okay? We're really, really searching for the oxygen like we typically do every day, but in all different types of shock, we're just not getting it, okay? We know oxygen travels everywhere, right? Oxygen travels through our blood. That's what our blood is made up of, is a lot of oxygen. So when we have that impaired supply and that impaired perfusion, what's going to happen to our organs, our tissues? Okay. It's all going to become very impaired. So what becomes imbalance? So we said what shock is, that decreased tissue perfusion, impaired cellular metabolism. So what becomes imbalanced? And we talked a lot about this already, and that's the supply and demand of oxygen. Like I just said, we're really searching for the oxygen like we do every day. It's our normal everyday routine for our bodies to do, to search for the oxygen, and we get it typically. But when we're in a shocky state, the imbalance becomes the supply. We're not getting enough supply for our demand, okay? We're not getting the bank as full of money as we should be, okay? So what's going on? Like I talked about, our tissues, our organs, they need oxygen. Oxygen travels through our blood, it runs through our body, and we get the proper oxygenation by perfusion, by oxygen running through our blood. But when we don't have enough supply, our tissues and our cells are going to become hypoperfused, meaning they're not becoming as well oxygenated as we want our body to be. Okay? We're not having that proper perfusion. And that's our body's response to shock. That's really what's going on here. Okay? We're not getting enough oxygen. Our tissues are not getting enough oxygen. Okay? So what can happen to our tissues, our organs, if we're not getting enough of that oxygen? Think about that heart muscle like we talked about last semester with MIs. If our heart muscle is not getting enough perfusion and oxygen through the blood, ischemia occurs, right? So our tissues become ischemic, all right? And they kind of almost die off. That's cellular injury and almost leading to death, right? Cellular death, organ death. That's why we eventually end up with multi-organ dysfunction, multi-organ failure when we're in severe stages of shock. It's all about the tissue perfusion, the tissue oxygenation. So ischemia, that poor perfusion, the poor oxygenated perfusion leads to cell injury and death. Hopefully we don't get to that point in shock. Do we see it all the time? Yes. But that's a stage we really, really want to try to not get to and hopefully fix the patient before we get to that cellular injury and death and multi-organ dysfunction and multi-organ failure. So really any type of shock is so life-threatening, right? And it's something that we need to try to fix right away so we don't end up in those later stages of shock. So we're going to go through all the different stages of shock at the end. We're going to talk about all the different types, and then we're going to go through some different stages and how our patients may present in each stage. Cardiogenic shock. Here's our first one here, okay? All right, so cardiogenic shock. Okay, so the main basis of cardiogenic shock is there's two types of dysfunctions here. So there's either going to be a systolic dysfunction or diastolic dysfunction. There can be both, okay? It can be one or the other or both. The main root cause that we typically see with cardiogenic shock is from acute MIs, typically severe MIs like the STEMIs we talked about last semester. Those can put patients directly into a cardiogenic shock because the MI is causing a systolic or a diastolic function. That's the most typical, okay? We're going to go over some other reasons why a patient may enter cardiogenic shock, but really that is the most common reason why. So back to dysfunctions. So there's either a systolic or diastolic dysfunction. We're going to get a little bit more into that into the next slide. But this dysfunction causes impaired pumping. We need our heart to pump, right? So our heart needs to pump to perfuse the rest of our body. That's what's going to oxygenate the rest of our body. And if we don't have that going on, we're in big trouble. So if we have a dysfunction and if we have an impaired pumping action, what decreases? Cardiac output, right? Cardiac output is so important. We want good cardiac output, meaning we need good blood pressure, right? Cardiac output kind of go hand in hand with our blood pressure. We want a really good, decent blood pressure. So a good, decent blood pressure, we need good cardiac output, right? So the two go hand in hand. So those are going to be impaired for sure. So I kind of answered your little question here. So what happens when there is impaired pumping action of the heart? We end up with decreased cardiac output, and of course our blood pressure decreases if we have decreased cardiac output, as like I said, they do go hand in hand. So that second question there, what happens to our blood pressure? It certainly decreases, yes. With either a systolic or diastolic dysfunction, we have impaired pumping action. We're going to have a decrease in cardiac output and, of course, a decrease in blood pressure. The mortality rate for cardiogenic shock is about 50%, so it's pretty high. And like I said, the leading cause of this is acute MIs, especially like the STEMI we talked about last semester. So really, our heart really can't pump enough blood to meet our body's needs. That's what's going on because of the impaired pumping action. So again, decreased cardiac output, decreased blood pressure. Okay, so we're going to get a little bit deeper into the dysfunctions. So the last slide we talked about systolic dysfunction and we talked about diastolic dysfunction, okay, both causing impaired kind of pumping of the heart. So systolic dysfunction, this is a perfusion issue, right? So when we have a systolic dysfunction problem, it's our heart's inability to pump the blood forward, meaning inability to perfuse the rest of our body, okay? Meaning we're going to have that decreased supply of perfusion and decreased supply of oxygen. A lot of times this affects the left ventricle, and I'm just curious as to why you think our left ventricle would really be affected with this systolic dysfunction. And this is because the systolic pressure is much greater on the left side of the heart. So that's why our left ventricle is so much affected due to the systolic pressure of being greater on the left side of the heart. Yes, it can also impact the right side of the heart. Where do you think the blood flow is reduced on the right side of the heart? And think about that anatomy way back at A&P, that blood flow through the heart and the pulmonary. This is going to greatly affect the pulmonary circulation if we do have an impact on the right side of the heart from systolic dysfunction. The most common cause of a systolic dysfunction is the acute MI, okay? So that's like the STEMI. Also cardiomyopathy. Blunt cardiac trauma. So if there was, if the patient has been through a trauma, such as, it could be like a car wreck or a fall, this could cause as a systolic dysfunction for cardiogenic shock. Also, pulmonary hypertension can cause a systolic dysfunction. Now, going to a diastolic dysfunction, this is when we have the inability of our heart to fill properly, okay? So with systolic, it's our perfusion and the inability to pump the blood forward. Diastolic dysfunction is inability of the heart to fill. So it's more of a filling action, okay, that is decreased. This can cause decreased stroke volume. We're not going to get too much into stroke volume, but really what the stroke volume is the volume of blood pumped from the left ventricle per beat, okay? You will not get tested on this. Just good to know that we have a decreased stroke volume if we do have a diastolic dysfunction, okay? Some different reasons of how we can get a diastolic dysfunction is if we have a cardiac tamponade going on, okay? And that happens when there's extra fluid that builds up around the space around the heart, okay? This fluid puts a lot of pressure on the heart and really prevents it from pumping well, and of course it's going to prevent it from filling well. Ventricular hypertrophy, enlargement of our ventricles, and then that tension pneumo. I think we've heard, I'm getting a little bit ahead of myself. Ventricular hypertrophy, enlarged ventricles, cardiomyopathy, enlargement of the heart, okay? Dysrhythmias can cause cardiogenic shock, so typically bradydysrhythmias or tachydysrhythmias can do so. And then structural factors too. So if we have like a valvular stenosis, a valvular regurgitation, ventricular septal rupture, or a tension pneumo. We may have talked a little bit about attention pneumo. We're going to get a little bit more into that when we get into our pulmonary courses coming up soon. But attention pneumo, it's a very, very severe problem. That's when air gets trapped in our pleural space and it causes positive pressure. It actually causes a pressure that's going to actually push structures, anatomical structures, over to the other side. So for example, if I get attention pneumo on the right side of my lung, okay, and I have air trapped in my pleural space, it's actually going to push my mediastinal structure and my trachea over to the left. So much pressure, it's going to push. It's also called tracheal deviation, mediastinal deviation. So that's what really goes on with tension pneumos. And it really, really compromises our cardiac function, our cardiopulmonary function. All right, so I took these little algorithms from Lewis. Shock is hard, right? Shock is a little bit hard to understand, but once you get it, it clicks. Once you figure out that everything is in relation to perfusion and decreased perfusion, it will click, okay? So this is kind of showing how really cardiogenic shock happens, whether we're in a systolic dysfunction or diastolic. So here we're starting off with a cardiogenic shock, and it breaks it up into two pathways. So remember, systolic dysfunction is that inability to effectively move blood and perfuse blood to the rest of our body. So it's more of a perfusion problem. And then diastolic dysfunction is that ineffective filling, right? So if we're going to look at systolic dysfunction, ineffective forward movement of blood, meaning ineffective perfusion. Our big thing to know, I know it says decreased stroke volume. Yes, that's great, but it's decreasing our cardiac output, meaning our perfusion is decreased, our blood pressure is going to plummet. That's the main thing to get with this, okay? Perfusion is decreased, cardiac output decreased, meaning that we're not, what's going to happen to our cells with our oxygen supply way down, right? Then what's going to happen to our tissues and our organs? Are they going to be perfused? No, not at all. So there's our impaired cellular metabolism right there. Okay, so that's how that that systolic dysfunction works. Then we move over to diastolic dysfunction. A little bit different because we have a filling problem now, right? So this kind of presents more as like a CHFE pulmonary congestion type. That's the main difference between systolic and diastolic. So if we're thinking if there's any sort of test question here, there may be, if you see any systolic dysfunction, what are you going to think of? Impaired perfusion, right? Impaired cardiac output, inability to pump the blood forward to our bodies. And if we're thinking diastolic dysfunction, we have an ineffective filling problem, meaning we're going to have backflow and we're going to have congestion issues. So that's going to bring you more to like a pulmonary congestion, CHF type of deal with diastolic dysfunction, okay? So when we have diastolic dysfunction, we have an increase in pulmonary pressures because we have a backflow, because we have ineffective pumping, right? We have ineffective filling. So that leads to backflow of our pulmonary system, meaning we're going to have increased pulmonary pressures, pulmonary congestion, pulmonary edema. We may hear crackles, right, in the lungs. Our patient may become very short of breath. And of course, that's going to lead to decreased oxygenation, meaning we're going to have impaired cellular oxygen supply, meaning perfusion is going to go down and impaired cellular metabolism is going to go down as well. We're going to have impaired cellular metabolism. These last three boxes, you see cellular oxygen supply, that's decreased tissue perfusion, impaired cellular metabolism. Every algorithm we're going to go through with all these different types of shocks, it's all going to be the same end result, okay? That's how similar each shock, different type of shock is. And hopefully by the end of this PowerPoint, it'll really kind of start to click on how much tissue perfusion is affected and how important it is to our bodies to survive on tissue perfusion. All right, so the real important stuff, how do these patients present? Okay, and you're going to see also not only a similar trend with all these decreased tissue perfusions with every different Shockey episode, there's going to be very, very similar clinical manifestations for each. We're going to see that tachycardia, right? So the patient's going to be tachy and they're going to be hypotensive, right? Heart rate goes up, blood pressure goes down. We know this a lot. We talked a lot about this in burns, right? That Shockey state in burns, they get that hypovolemia. Very, very similar, right? Very similar thought. Tachy, low blood pressure. Every shock almost presents like this. There's going to be one that doesn't, but this is the most common. Narrowed pulse pressure is a big underlying red flag for cardiogenic shock, okay? You're like, what is a narrowed pulse pressure? That's a weird word. Haven't heard that before. So that is when you see a blood pressure with numbers that are actually very, very close. So for example, you may have a blood pressure that reads 90/70. Not too far apart, right? So that's what a narrowed pulse pressure means. It's not a blood pressure that's reading 180/60. That's pretty wide, right? That's a wide pulse pressure. Narrowed pulse pressure, again, another example would be a blood pressure 85/65. Very close in numbers, okay? So really, your pulse pressure is 1/4 or less of your systolic, your top number, okay? So a narrowed pulse pressure happens when your heart isn't pumping enough blood. A lot of times this is seen a lot in certain types of heart failure or heart valve diseases, okay? So again, narrowed pulse pressure, meaning your systolic and diastolic numbers are very, very close in numbers. 90/60. Could be 80/60. Very, very close together. Typically, if you were to take the difference between your systolic and diastolic, if it's below 30, that means it's narrow. So again, 90/70, that would be like 20. So that would be a narrowed pulse pressure, right? So anything with that is below 30, if you take this difference between your systolic and diastolic and it's below 30, it's most certainly a narrowed pulse pressure. The patients may present as tachypnic, meaning that they're breathing fast, right? The respiratory rate is fast and they're over breathing, trying to compensate a little bit, right? We're going to hear crackles on auscultation. And why is that? Especially with a certain type of dysfunction. What type of dysfunction may we hear crackles more? The diastolic, right? Because we have that ineffective filling, meaning that leads to backflow into our pulmonary system, and that's pulmonary congestion, meaning we'll probably hear crackles on auscultation, especially if we have that diastolic dysfunction. Again, can we have both? Can we have a systolic dysfunction and a diastolic dysfunction? Most certainly. You can have both at the same time, but always hone in on systolic dysfunction means that that's more of a perfusion problem, pumping to the rest of our body. Diastolic is the filling, and that's going to lead to more pulmonary congestion. Cyanosis, yes. Are we going to look pale? Yes. We have poor perfusion going on. So we are going to look probably a little cyanosed, okay? We have decreased perfusion, decreased oxygenation. Confusion, anxiety, agitation. What is one of our most important organs that really, really lives off of oxygen? Our brain. And our brain is the first one that's going to be affected by decreased perfusion. Okay, that's always your first sign is your confusion, right? So if we have any confusion, anxiety, agitation, altered mental status, right? Mental status changes, it's kind of a red flag to say, are we properly oxygenating our patient? Are they getting enough oxygen to their brain? Yeah, they can be diaphoretic, cool, clammy. How our peripheral pulses feel? Probably pretty weak and thready, right? If we have that decreased perfusion, that impaired perfusion, impaired pumping, decreased cardiac output, peripheral pulses aren't going to be that great. That's why it's always so important to go through your head to toe assessment really, really well, right? We don't want to miss anything. It's good to feel those peripheral pulses, those radial pulses, those pedal pulses. How is their, CSMs, color? It's so, so important. That's why I really hone in on that great head to toe assessment, being very, very detailed with it, because you can always catch something by that good detailed head to toe. Like I just mentioned, that delayed capillary refill, checking those CSMs, right? Of course, that leads back to our impaired tissue perfusion. Decreased urinary output. So this is going to be a very common theme as well. So yeah, we're going to talk about the heart. Yeah, we're going to talk about the brain. We know the brain's pretty much always going to be that confusion, agitation, altered mental status, because we're going to have that decreased oxygenation. But what happens to our other organs, right? If we look at our kidneys, it's going to happen to our kidneys if we have decreased perfusion and oxygenation. Are they going to work as well? No, they're not, right? We're going to have that decreased urinary output. Our kidneys are not going to be producing enough urine as they're used to. Okay? Same thought as our GI system. Is it going to have that normal peristalsis if we have decreased perfusion, oxygenation? No, that's going to slow right down. So you're going to see that common trend as well with all the other organ systems. And like I said, it's going to click as we get through each shock, different shock type. We may have an increase in sodium levels. We may have an increase in water retention with cardiogenic shock. And I think we have everything on this slide. Okay. So like I said, like head to toe assessments, those detailed head to toes, those are key. Those help with diagnostics a lot. Okay, vital signs are going to help us for sure. That good head to toe. But yeah, we do have some diagnostics too. We can do some labs. Remember we talked about troponins? We talked a little bit about that in last semester with cardiac, especially when we talked about MIs. So troponins are cardiac biomarker, right? And what does that troponin pick up? Why do they get elevated? When we have any sort of injury going on in our heart, we're going to have elevated troponins. So those are certainly going to be elevated. So if we're in any cardiogenic shock, we're going to have an elevated troponin level. So that's a really important lab tool to use in cardiogenic shock. Elevated pro-BNPs. We talked a little bit about pro-BNPs with PEs, right, when we talked about pulmonary embolisms. Because remember, when we have that clot in our lung with a PE, it causes backflow. And it causes almost that CHF type of look, especially, that right ventricular heart strain, right? And what's going on here in cardiogenic shock, especially if we have that diastolic dysfunction. We have that impaired filling, meaning that we have pulmonary backflow and congestion, meaning we're going to present pretty much CHF-y, right? We're going to have almost like a CHF presentation. We're going to have pulmonary congestion. Those pro-BNPs pick up pulmonary and cardiac congestion. So when they're elevated, they're picking up congestion. We do these a lot on CHF patients all the time, okay? So we may see an elevated pro-BNP. Elevated glucose, you're like, well, that doesn't make sense. Why would we have an elevated glucose? Any type of shock syndrome we're going to go over today, what elevates when we have stress in our body? Starts with a C. Cortisol, right? Cortisol is highly affected with glucose. They kind of work hand in hand here. So when we have elevated cortisol due to increased stress because our body's going through a very traumatic event with shock and stress, we're going to have elevated glucose levels for sure. And you're going to see this as a trend with each shocky type of syndrome we're going to go over. Elevated BUN and creatinine, yes, we're going to see all different types once we start getting into like organ dysfunction. We are going to see, especially if we're going to do like a liver panel, we're going to see liver panels that may look off. If we're going to do kidney functions, those are going to be elevated. So think about every organ system and what that shock is doing to every organ system. Okay, it's going to be similar for each. If we were to take an echocardiogram on a person with cardiogenic shock, we may see that left ventricular dysfunction. And chest x-ray, we may pick up on that congestion, especially if it's that diastolic dysfunction. Okay, so we'll see that pulmonary congestion. We may even see a little congestion around the heart. All right, so managing cardiogenic shock, our job, nursing measures, right? How do we care for these patients and with cardiogenic shock? So you're going to hear me say this a lot, okay? Oh, with all the different shock types, maintaining patent airway is huge, okay? Hemodynamic management. This is a real big one, right? We're monitoring their vital signs. A lot of these patients are really, really sick. They end up in critical care. We're always taking a constant measure of their blood pressure, looking at their heart rhythms. Is their heart rate? Sometimes we do a little bit more invasive monitoring on them. But we'll get a little bit into that a little further, and also giving them medications to treat their hemodynamics, whether the blood pressure is, plummeting, are they in a dysrhythmia. This goes alongside with maintaining a patent airway, but providing that supplemental O2, right? We know they probably most likely will need some sort of oxygen therapy, especially because their perfusion is not good, right? Their cardiac output's low, meaning that the rest of their body isn't perfusing. So we may need to help them out with some oxygen at this time, whether it be a nasal cannula. Do they need a non-rebreather, mechanical vent? So we have a whole rainbow, a whole slew of all different types of oxygen therapies. And depending on how the patient's presenting is kind of how we would help treat the patient with their oxygenation status. How can we restore blood flow? This is huge. So this is the most important aspect, and this is how we're going to correct and fix patients with cardiogenic shock. We need to restore their blood flow, whether if it's a more of a systolic dysfunction, meaning that we have a perfusion problem, or more of a diastolic dysfunction, meaning that we have a filling problem. Both problems mean that we need to restore heart function, right? And by doing this is that the patients typically need a cardiac cath. We talked a bit about that in last semester, of course, with like acute MIs, especially STEMIs, even not NSTEMIs do need cardiac caths. So this should be done as soon as possible, and this is actually what's going to save the patient, right? So we're going to restore heart function. We're going to regain that oxygen balance, the oxygen supply, and that perfusion will be restored. So with that cardiac cath, this patient's most likely going to need stenting. They may need an angioplasty. Remember, going back to the causes, yes, acute MIs is the most common cause, but there is also, remember, the structural defects like valvular stenosis. Do they need valve replacements? So kind of looking at everything and figuring out what's the main cause of the cardiogenic shock and fixing that main cause, right? Is it a tension pneumo, meaning do they need a chest tube to relieve the pressure off of the mediastinal structures, so it's not causing that tracheal deviation or that shifting, which is causing compromising, the compromising of the cardiopulmonary function. Meds, okay? We're going to go over meds in detail later on in this PowerPoint, but I wanted to put the specific medications of treatment with each different shock type, just so you have it in your mind, okay? So nitroglycerin, dobutamine, and furosemide are the three big ones for cardiogenic shock. Okay. Especially, which one do you think, if we have a diastolic dysfunction, is going to be most helpful? That Lasix, right? The furosemide. That's going to help with the pulmonary congestion, the cardiac congestion. And nitroglycerin is huge. That's going to kind of help that perfusion, help that cardiac output, as well as dobutamine is going to help uptake that cardiac output. So nitro and dobutamine are both great indicators to increase, help out a little bit with the pumping action and perfusion and help that cardiac output. Furosemide is going to help, especially if they have that diastolic dysfunction, help take a little bit of fluid off, okay, and help decrease pulmonary congestion. If they do have any dysrhythmias, we're going to treat the dysrhythmias appropriately. Okay, so that's it on cardiogenic. Next, we're moving on to hypovolemic shock, and you guys are like pros on this because just got done with burns, talked a lot about hypovolemic shock with burns. So you'll be pretty aware and pretty attuned to what is going on with hypovolemic shock. So really what's going on is we're going back to our spaces here, intravascular, extravascular, and where do we want our fluid to be? Our intravascular space, right? Because that's where our perfusion is happening, right? So the more volume we have in our intravascular space, the better our perfusion will be, the better our blood pressure will be, okay? The better our hemodynamics will be. So we're going to go over some reasons of why we may not have adequate fluid volume in our intravascular space. Okay, so there's two different types of ways we can lose fluid. There is absolute versus relative. All right, and so I really, really want you to know the two different types, okay, and what causes what. So absolute hypovolemia is actual fluid loss. So we're actually losing fluid out of our body, okay, out of the body. So this is fluid loss. It could be by hemorrhage, whether it could have been a birth, it could have been a trauma, it could have been surgery, the patient's vomiting too much fluid, too much diarrhea, fistular drainage could be huge output, huge fluid loss, diabetes insipidus, or too much diuresis. So that's actual fluid leaving the body itself, okay, is absolute. Absolute leaving the body itself. Versus relative, so going to relative hypovolemia, meaning that this is kind of like what you are used to with burns, what we talked about with burns. So the fluid isn't necessarily leaving the body, but it's leaving the space we need it to be in, right? So where do we want our fluid to be in? What space? Intravascular, right? We want our fluid to be in our intravascular space, but with relative hypovolemia, this is a problem where it's moving out from our intravascular into our extravascular space, meaning it's a space that doesn't even help us out, right? It's that extra closet. It's not doing anything for us. And all it's creating is what we call third spacing and edema. Okay, and it's not helping our hemodynamics. It's not helping our blood pressure because we have a huge loss of it coming out from our intravascular. So some common causes to this, really not much, but really burn injuries are huge, and your pros on this, and ascites, meaning if a patient is kind of more end-stage liver disease, we see relative hypovolemia with. So really what's going on is we're losing fluid, whether is it absolute or relative, it's both coming out of our intravascular space, but absolute meaning it's leaving the body as a whole, relative meaning it's leaving our intravascular space and going into a different space in our body, okay? So when we don't have that good intravascular volume, we're going to have poor venous return to the heart because we have poor perfusion and because we have decreased cardiac output. So pretty much kind of that same thought process that we talked a little bit about with cardiogenic, We're now adding it to hypovolemic due to fluid loss, okay? All right, so here's our algorithm again, okay? Pulled these from Lewis. I think they're just helpful to see a visual of what happens in each stage. So whether we're going through a relative hypovolemia or absolute hypovolemia, we're going to end up with decreased volume in our intravascular space, right? Decreased circulating volume, meaning that our volume in our intravascular space where we want to have the most volume is missing. Meaning we're not going to have good hemodynamics. Our venous return is going to be horrible. Our cardiac output is going to be horrible, meaning we're going to have poor oxygen supply, meaning our tissue perfusion is going to go down. We're going to not have tissues that are oxygenated, and this is going to cause impaired cellular metabolism. So like I said, it's going to be the same story every single time with every shock state we're going to talk about. So what are these patients going to present like? Pretty similar, right? So we're going to have that tachycardia. We're going to have that decreased blood pressure. So hypotension, tachy. How's our going to be our peripheral pulses and our cap refill? Decreased, right? Poor perfusion, meaning we're going to have those very weak, thready pulses. Capillary refill, poor perfusion. It's going to definitely be more than that 3 seconds, right? Tachypnea, our body's trying to overbreathe, meaning that we're trying to compensate for what's going on. We know that we're in shock, our body does at least, and we're going to try to fix itself. Here we go on to our other organs, okay? How's our kidneys going to work if we have decreased perfusion? Not well, meaning we're going to have decreased urinary output. How's our gut going to be working? Peristalsis will probably be slowed, if not working at all, okay? Very similar to what we talked about with burns, right? We knew it was a normal finding, especially in that early stage of burns. Our gut is not as important, right, as our heart and our brain. So it's just not going to function as well. So we'll probably have that paralytic ileus, right? We're going to look cool, or we're going to feel cool. We're going to look pale, maybe clammy. Again, think about poor perfusion to your brain, anxiety, confusion, agitation. Think about everything that goes on with each organ system. And if you have poor perfusion to whatever organ system, what's going to happen? And we talked about the absent bowel sounds. So pretty interesting, and I know you guys are going to get this. So I just wanted you to pick apart, especially if we're going to take a blood value. Say we're going to do a CBC, complete blood count, and we're going to look at our hemoglobin and hematocrit. With an increased H&H, what type of volemia do you think that will be? Okay, so going back, think, okay, relative, absolute. What type of hypovolemia do you think can cause an increased H&H? Very, very similar to burns, right? So here's our vessels. We have our intravascular space, and we know our blood runs through our intravascular space, and we know water does, and we know sodium does, and we know plasma does. So when all that fluid comes out of that intravascular space into our extravascular space, what's left? Blood, right? And it becomes very thick, very viscous. You think we'll see an increased H&H? Absolutely, yes. So what type of hypovolemia will that be? Relative, right? Because relative, that's burns, that is ascites. And so with decreased H&H, we know that that's going to be like actually absolute hypovolemia, right? Because the blood is actually leaving our body. The fluid's actually leaving our body totally. Okay? So we're going to see that actual drop in our blood levels in H&H. So I just thought it was very interesting, that you guys would like that, and I know you'll be able to pick that apart. With every shock state, you're going to see an increase in venous lactate. Cardiogenic, hypovolemic, whatever one we're going to talk about, you're going to see that venous lactate pop right up. And why do you think that is? It all comes back to that cellular metabolism, right? So if we have that horrible perfusion, that horrible cardiac output, and our tissues and our organs are not being perfused, that means they're becoming ischemic. And when we have ischemia, that means we're leading to tissue and cellular death and poor cellular metabolism, meaning that we're building up acidosis, a lactic acidosis in our bodies. And that's really the basis of why we have elevated venous lactates. I hope this finally clicks with you guys on why venous lactates can be elevated. That is the whole song and dance to why venous lactates can be elevated, is really tissue perfusion, horrible tissue perfusion, tissue death, ischemia, and it's just the breakdown of our tissues. And when we have increased venous lactates, it's picking that up. Okay, so with every shock state, you're going to see that increased venous lactates. With hypovolemia, we may see an increase in urine-specific gravity and definitely total electrolyte shifts, right? So if we have an outpouring of fluid or, along with an outpouring of blood and plasma possibly, we can see definitely electrolyte shifting, our K may be way down, what's our magnesium look like? What's our sodium look like? Everything's going to be totally off. All right, so we're back to nursing. What can we do? How can we help these patients? So again, you're going to laugh. Patent airway, it's huge, right? Maintaining that patent airway with what supplemental oxygen do they need depending on how they're presenting? Nasal cannula, non-rebreather, mechanical vent. Do they need high flow? Do they need a oximizer pendant? Do they need a Venturi mask? Do they need BiPAP? Whatever they're presenting like, they would be offered the, supplemental oxygen and oxygen therapy that they need. Again, hemodynamic management. We know we're going to be taking constant blood pressures, constant readings of their heart rate, their rhythm, and like I said, possibly even invasive monitoring, which we'll get to. Typically, providers like to do the 3-to-1 rule, meaning that when a patient is in hypovolemic shock, they're going to get 3 mLs of an isotonic solution for every 1 ml lost. So they really try to get a good history and a good grasp on how much fluid the patient has lost, especially if it's the absolute hypovolemia that they're going through. They're going to get 3 mLs of every 1 ml loss. Okay. So we're tripling for every 1 ml that has been lost. And that, again, of course, would be absolute hypovolemia because we're actually losing the fluid out from the body, right? Best practice, always 2 large bore IVs, especially if they're getting tons of boluses of fluid. A central line may be needed if they're getting multiple blood products, if they're getting, multiple bags of fluid, medications. An IO, also meaning intraosseous, may be also needed, especially if the patient was found in the field and it's emergent and we cannot get a line. We would have to be putting fluids through the bone. Replacements. Normal saline is very, very common. Lactated ringers. Packed red blood cells. Do they need blood products? Do they need fresh frozen plasma, FFP? Do they need platelets? And albumin can be very common, especially if this was more of a relative hypovolemia, right? So if we have the burn issue or the ascites, and we have that third spacing because our fluid has gone into our extravascular space, albumin is such a helpful drug for that, and it pulls the fluid right back into the intravascular space. We see this given a lot, especially with end-stage liver patients. Correcting the cause. Why did this patient lose the fluid? Was there too much diuretics given? Was this a trauma and they need blood replacement? Getting down to the direct cause of what was it relative? Was it absolute hypovolemia? And does this patient need warmed fluids? A lot of times if they are, in that hypovolemic shock, it is good to warm the fluids, especially if they're getting it through a rapid transfuser. Fluid should always be warmed, or if it's going through a central line. So that is hypovolemic shock, and we're moving on to distributive shock, which actually has 3 different subtypes. So we're going to talk about neurogenic, anaphylactic, and septic shock, and these all fall under distributive shock. Okay, so first type of shock under distributive shock that we're going to talk about is neurogenic shock. This one's pretty interesting. This occurs, it's typically from a spinal cord injury. So it occurs within 30 minutes of a spinal cord injury. And this is when it's affected with the cervical or high thoracic area. This is going to be at or above T5. Okay, so T5 and above, we could majorly expect a neurogenic shock consequence. And what happens is there's a lot of hemodynamic changes and consequences with the spinal cord injury, and we'll get to that in a second. So this can last up to about 6 weeks, like I said, at or above T5 for the spinal cord injury. And what happens is when we have this injury, we have a huge loss of our sympathetic nervous system, or our tone, okay, our SNS tone, sympathetic nervous system tone. And what happens is our vessels get affected. Typically, if our vessels, think of either a garden hose or actually like a fire hose. So a garden hose, fire hose, or another good way to look at it is actually like a water ride. So you know how you got the smaller water rides, and those are sometimes like the smaller in diameter, the tubes. And then you have the larger tubes in diameter. Which one typically goes faster with your tube? The one that's smaller, right? The smaller plastic water ride. Typically, people go a lot faster down those. The large open rides, it's a little bit slower. So that's kind of the same thought of what's going on with our blood vessels. When there's vasodilation, we have the big wide tube ride. So it's a little bit slower. So what happens is our blood's not pushing fast enough. It's not pushing through our vessels fast enough with vasodilation. When there's vasoconstriction, it's really going to pump that blood through a lot faster. So when we have more vasodilation, we have slowing of blood through our vessels. We're going to have some pooling, and we're going to have, of course, hypoperfusion. Because if we have pooling in our slower blood, we're not going to get as much perfusion to the rest of our tissues. Okay, so that's what happens when we have a loss of a sympathetic nervous system tone. And that's like a huge indicator for neurogenic shock. This can also happen if a patient undergoes spinal anesthesia. We could have a neurogenic shock type of thing going on. So what happens is there's depression of the vasomotor center in the medulla. I don't want you to spend too much time on that. I really care about the cervical or thoracic injury at or above T5. Okay, and just please understand that there's massive dilation when we lose that sympathetic tone. So here's our little algorithm or flow sheet for for neurogenic shock. So what happens? We have our injury, right? Whether it's from a trauma and we have a cervical injury, T5 or above, or it could be from a spinal anesthesia. So we have the injury in whatever form, and then we lose that sympathetic tone. We're losing that SNS, meaning that we're going to have huge vasodilation, slowing of our blood flow, okay? Meaning we're going to have decreased cardiac output, meaning decreased blood pressure. And then this all comes back to our oxygen gets depleted, tissue perfusion goes down, and of course it impairs our cellular metabolism. Okay, neurogenic shock. How are our patients going to present? So just remember we have that massive vasodilation going on. That's going to be a little bit different with this type of shock, okay? Just keep that in mind. We're going to have hypotension, okay? And we know that we have massive vasodilation. We're in a shocky state. We know our cardiac output is decreased, and our blood pressure, of course, will be decreased because of that, right? Bradycardia, you're like, ooh, that's different because usually we're hypotension and we're tachy. So this is the one that's different. So neurogenic shock should stick out in your mind that these patients are going to be Brady instead of tachy, okay? And that's due to vasodilation. So we're vasodilating. When we lose that sympathetic tone, our patients get Brady, okay? So that's a really, really good indicator to know that your patient has a neurogenic shock. We know that there's a decrease in cardiac output, vasodilation. We have loss of venous return. We don't have that good pumping scenario and good perfusion. Because of the loss of sympathetic tone as well, the patient is not able to regulate their body's temperature. So 1 second they could be really, really, warm. We could have a temp of like 102, and then the next they may not control their temperature and they may lose it to 96. So maybe increased, maybe decreased. There's just no control, okay? And that's a lot of neural control. So when we lose that sympathetic tone, we're losing our ability to regulate our body's temperature. We may find that upon initial injury, if you were to palpate the skin or touch the skin, it may feel warm, and that's due to that initial vasodilation. You may feel the skin may be warm. There may be some respiratory dysfunction, and that's a lot to do with the neuro changes, right? So we lose that sympathetic tone, and there's some neuro disruption, and there could be some respiratory dysfunction as well. So our respiratory rate may be lower. Patients tend to lose bowel and bladder dysfunction, okay, and that falls along with the cervical injury and also the loss of the sympathetic tone. We may see flaccid paralysis below the level of the injury. That's very typical. And the patient may lose loss of reflexes. Okay, so nursing care. How do we care for patients with neurogenic shock? So these three are always the same for any type of shocky state. We're maintaining a patent airway, and what supplemental oxygen do they need if we need to maintain that patent airway? Could they use a nasal cannula? Do they need a BiPAP, non-rebreather? Do they need high flow? Do they need a Venturi mask? Do they need mechanical ventilation? So it could be a whole slew, a whole rainbow of things depending on how severe they're presenting. And of course, the hemodynamic management, we're going to always be monitoring their blood pressure, their heart rate, their heart rhythm. And like I said, there could be more invasive measures that we could use to be monitoring their hemodynamics. And again, a lot of these patients in all the different shock states most likely will be in critical care. So this is a good one. Underline this one. Like I said, we're going to talk about meds in a little bit, but most under every shock state, I did add a medication that is vital to that certain shock state. So phenylephrine, also known as neosynephrine, we'll get to that, is the main treatment actually for neurogenic shock. And the main reason for that is it helps with treatment of hypotension and also bradycardia. So that's why phenylephrine is the drug of choice for neurogenic shock. Also atropine, if the patient has severe bradycardia, that can help bring up the heart rate. And we want to minimize any spinal cord injury further. So of course, when they're found in the field, and if we're treating them, of course, in the emergency department, even when they get to the floor, if they're in critical care, we're going to maintain that cervical stability and C-spine, right? So that's really important. We're keeping the neck stable. We're keeping them in a collar. We're log rolling. And they may need to maintain on a hard board. Monitoring temperature. We know when we lose that sympathetic tone, the patient may not be able to regulate their body temperature on their own, so it's very important to monitor that. And infuse fluids cautiously. Is it a big deal that they receive fluids? No, not at all. But we need to remember that their hypotension really is not related to like fluid loss like it would be with hypovolemia. This is all in regards to their neuro changes because of their spinal cord injury. So this is all because of loss of SNS. So just keep that in mind, that we're not going to really flood them with fluids. because it's unlike any other. It's not like a hypovolemia. It's not like a septic shock. It's not where a state where we're losing fluids out of the intravascular space. It's an issue with the neuro type of component of this. It's a neural component. We have a cervical injury, and we have a loss of sympathetic tone. Okay, so moving on to anaphylactic shock. I'm just finished up with neurogenic. So anaphylaxis, it's an acute, it's very sudden, and it's very life-threatening. So it's a hypersensitivity reaction to a substance. And it's typically a substance that the patient has had contact with before. So they have to build up that hypersensitivity to it. So it could be a certain drug, okay, that they have a hypersensitivity to. Could be a chemical, a vaccine, any sort of food. A lot of people are allergic to shellfish, insect bites. I know I'm allergic to bees. Any allergens. It could be contrast media. That is actually very common, and a lot of times we hear if a patient has a shellfish allergy, we should be very careful with giving contrast to patients because it kind of acts in a similar type of manner. Could be blood products. It could be chemotherapy, drugs, just to name a few. So what is going on here is we have a massive dilation problem, okay? So massive vasodilation. What's a little bit different is because we have a little bit of an increase in cardiac output here. What's going on with anaphylactic shock is we initiate that fight or flight. So what's a little different is the cardiac output increases, but we have massive vasodilation. So our perfusion is down due to the vasodilation. And we have a huge increase in capillary permeability when we're going through an anaphylactic shock. Okay, so what does that mean to you again? And you should know capillary permeability, very, very good from burns. So it's when we have that inflammatory process, it's our body's response to inflammation, and our capillaries become leaky. And of course, what's leaking out of the vessels that we need is the fluid from our intravascular space is going into our extravascular. So we're going to have a lot of third spacing going on with anaphylactic shock. And that's just our body's response. So how would our patient present if they're in an anaphylactic shock? Okay, so these patients may present as tachycardic. They're going to present with hypotension. So we're back to that regular type of shock, tachy, hypotension. They may complain of some chest pain, chest tightness, and we're going to have that third spacing of fluid. We're going to see, a lot of edema going on. And why is that? The leaky capillaries due to the inflammatory response from the anaphylactic reaction. Short of breath is huge. Okay, we're going to have, it's a lot of respiratory issues, most likely with anaphylactic shock. We're going to have large amounts of edema throughout the larynx, the epiglottis. We're going to have bronchospasms going on. And when we have that constricture and that edema, we're of course going to hear that stridor and wheezing. Okay, so that's a really, really emergent situation that needs to be taken care of promptly. So always monitoring their airway status is really important. Urinary incontinence, angioedema, so swelling of the face. The patient may have swelling of the lips, the tongue, the eyes. We may notice some skin flushing, and that's in reaction to that massive vasodilation. They have that feeling of like that impending doom, anxiety. They may present with some confusion, abdominal cramping, nausea, vomiting. I tell this story about, what I experienced just with anaphylaxis. I haven't really experienced really much of anything in the hospital. I've cared for patients post-anaphylaxis, but nothing really within the emergent stage. But I know just finding out with my husband, we had gone out to dinner at Kodo, and he's never really been a big fan of seafood, but decided to try the shrimp that they throw at you on your meals, and all of a sudden it happened very, very quickly. He ate the shrimp. He's never had shrimp before, and all of a sudden he had the angioedema going on. You could see his lips became very large and swollen. And then all of a sudden he's complaining of hoarseness, and you could hear his voice change a little bit. And he said his tongue felt big in his mouth. And so we left very quickly, and we were able to get Benadryl. It wasn't to the fact of like an anaphylaxis reaction, but it was my really only, I guess, experience I've had with this that was more acute. And just with the abdominal nausea and vomiting, as the shrimp kind of went through his body, it kind of affected every part. So once it got to his GI tract, he most certainly had the cramping, nausea, vomiting. So I got to kind of see it in every body system. So that is just I'm sure everyone in this class may have had an experience with some sort of anaphylaxis or allergic reaction before. So how do we care for these patients with anaphylaxis? They're in anaphylactic shock. What are we going to do as nurses? So we know these three are in every type of shock state that we've talked about so far, but we're a little bit more apt to lose the airway with anaphylaxis shock, right? We know that our respiratory system is very compromised, and we know that we have edema. We know that we have bronchoconstriction. So that's going to be like a huge red flag for us. A lot of times these patients do typically end up intubated just because it's so acute and it's so fast acting. We wouldn't want to lose their airway. We talked about hemodynamic management. That, of course, is very important. We're going to treat this patient with aggressive fluid resuscitation, okay? Normal saline can be very indicative. Lactated ringers is also very common. So we're going to administer, these are 4 important drugs that are all attached to anaphylaxis shock. And if you've gone through that emergency cart at BMC, you'll know right away kind of what's in that kit. So if you're picturing the emergency cart, there's a slide drawer on the top of the cart, on the very top, and it slides open. There's an anaphylaxis kit within that drawer. So within this kit is epi. Okay, that can be given IM or IV push, epinephrine. An antihistamine, also known as Benadryl, is in that kit. A bronchodilator, albuterol, is in that kit, so it's an updraft to try to open up the airways. And a corticosteroid, also known as Solu-Cortef, would be in that kit as well. So those are 4 major important drugs that come along with the anaphylaxis shock. So just know those drugs, and know epi is your very important life-saving drug. Epinephrine is going to be needed to help get this patient out of anaphylaxis. And of course, we need to identify and remove any offending cause. Okay, what caused this? So looking back at the history, what happened to this patient, and how can we correct this? Okay, so we're moving on to septic shock. Okay, this is one we see all the time, but it's very, very life-threatening. That's why when patients come in with any sort of infection, it's huge to really keep a close eye on them and monitor them so they're not entering a septic shock, okay? We had a little introduction with this last semester. Remember, we talked about pneumonia, and I introduced the septic, the sepsis protocol to you guys. So we'll kind of go over that a little bit again. We'll talk about the sepsis protocol again, just so everyone's on the same page and everyone's reminded of what goes on. So septic shock, it's really when a microorganism, enters our body, and we have our normal immune response is triggered, but our inflammatory response is triggered as well. Okay, so if you remember from pneumonia, we get that triggering of that inflammatory response, and because of the inflammatory response, we get those what kind of capillaries? The leaky ones, right? So it happens with a lot of inflammatory responses, and of course, a lot of these shock states that we're talking about today, we end up with those leaky capillaries. Okay. So when we're in septic shock, this response becomes extremely exaggerated. The inflammatory response is extremely exaggerated. Our leaky capillaries are extremely exaggerated. So we know we're going to lose a lot of fluid out of the space we need it in. Okay. So That's why our patients get so sick and so hemodynamically unstable, is because that exaggerated inflammatory response causing those huge amounts of leaky capillaries. We know that, of course, leads to, we're going to have that huge tissue hypoxia and decreased perfusion. This is when, severe organ dysfunction can occur, okay, especially if we haven't treated it quickly enough. That's why that sepsis protocol is so important. So hopefully this will make a full circle for you guys today. There's a huge high mortality rate, about 25% or higher, with septic shock. And really the gram-negative or gram-positive bacteria is the most common cause for septic shock. Other things that can cause it, parasites, fungi, any viruses. And really what's going on is that you see this patient, and a lot of times, no matter how much fluid you're giving them, they may have this persistent hypotension. Okay, so that's like a big red flag. So that persistent hypotension despite adequate fluid resuscitation. And that's why a lot of these patients need to go to the ICU. And we'll talk about, medications a little bit further on. So inadequate tissue perfusion, okay. We know that we're going to have tissue dysfunction, organ dysfunction because of the hypoxemia to our tissues, right? They become ischemic. So we have major vasodilation going on. We have maldistribution of blood flow, okay, because of that decreased perfusion, and we can have myocardial depression. Okay, so this flow sheet for septic shock is a little bit more confusing to look at, but still may be helpful for those of you who may be more visual learners. So we know at the top that we have some sort of invading microorganism, and like we said, gram-positive or gram-negative bacteria are the most common. And what's going on is we have that automatic initiation of the inflammatory response. So where that says endothelial damage, that's our inflammatory response. Because we have that huge inflammatory response, we're going to have that increase of capillary permeability, meaning we have those leaky capillaries, meaning we're going to have a lot of third spacing and a lot of fluid coming out of our vessels of where we need it to keep our blood pressure up, right? So we're going to have some vasoconstriction, some vasoconstriction, some vasodilation. We're going to have decreased perfusion. In a nutshell, just know that we're going to have decreased perfusion to our tissues, to our peripherals, which leads to maldistribution of blood volume, right? And of course, our oxygen demand, we need more oxygen. We're not getting it. Our cellular oxygen supply is going down, meaning we don't get enough good tissue perfusion, and there's our impaired cellular metabolism, okay? All right, so septic shock, how do these patients present? So here we have that typical shocky state. We are tachycardic. We're going to have some major hypotension going on. And because that there's a microorganism invading their body causing an inflammatory response, we most likely will have a fever. So we'll have a fever greater than 100.9, or the patient also may be hypothermic. We see this a lot in the elderly, and we talked a little bit about that with pneumonia. So a temp less than 97. So don't forget that they can also be hypothermic too. A lot of times that is missed in septic shock. We're going to have some myocardial dysfunction. So we're going to have decreased cardiac output, okay? Just because we're not getting that good venous return back, right? So if we have that decreased perfusion and that decreased oxygen supply, we're not going to get anything good back to the heart. So it's just a continuation. That's a big circle. It's a continuum. We're going to see that the patient may have some, they're going to be over breathing because they're going to be trying to compensate. So, we may see some tachypnea, also known as hyperventilation. So that's our compensation mechanism. We're going to talk a lot about compensation when we get to the different types of shock states. We have levels of shock. So we're going to get more into that. I have here in parentheses respiratory alkalosis or acidosis. When we're compensating and the patient's tachypnic or hyperventilating, if we were to take an ABG on them, do you think it would read at respiratory alkalosis or acidosis? when we're compensating, that is going to be a respiratory alkalosis, okay? Because our body's still trying to fight, our body is still trying to overbreathe and trying to fix itself. When we're in more of a respiratory acidosis, our compensation has decreased and we're no longer trying to fix itself. It's not a good level that we want to be in, okay? So we hyperventilate initially to try to compensate, to try to fight. It's just our body's way of trying to fight off what's going on. And once we have lost the compensation, our body's pooping out a little bit, we're gonna be more in a respiratory acidosis when we're more hypoventilating. Okay. These patients may become hypoxic. They may become in a respiratory failure. A lot of these patients may need mechanical ventilation. 85% of patients develop respiratory failure. And we're going to get into this a little bit later in the semester, but ARDS is known as acute respiratory distress syndrome. And this is when our respiratory system and our lungs are greatly affected by the sepsis. About 40% of patients continue into acute respiratory distress syndrome, and that's so severe. And we're going to get into that a little bit later in the semester. Of course, if we're going to go through the rest of our systems, our kidneys aren't going to be functioning properly due to the decreased perfusion. So we're going to see a decrease in urine output. We're going to see a paralytic ileus because our gut is not working. Our peristalsis has shut down at this time. We may see that our patient's skin at the earlier stages are more warm and flushed, and then they may turn to more of a cool, clammy, mottled skin. Of course, if we're thinking of our brain, they're going to present with that altered mental status, that agitation, confusion. So like I said, if you think about all the different systems in your body and how it's related to a decreased perfusion, you're going to be pretty good at understanding what's going on with each different organ and each different system of the body. So how do we care for a patient in septic shock? Okay, so here's our 3 that we know we're going to be doing with every shock state. Maintaining a patent airway, and depending on how severe they are, they need a nasal cannula, or to the most severe, a mechanical vent. And they can be anywhere between, okay? Hemodynamic management. We talked about that a lot, and we're going to continue talking about that. Aggressive fluid resuscitation, okay? 30 mLs per kg for the patient, okay? We know we're going to be giving them boluses. Passive leg raise challenge. We're going to go on about that in the next slide, but that is kind of an old school way to determine how much fluid is needed and if our patient is going to be responsive to fluid or not. These are some meds, and like I said, our meds are going to come a little bit later, but these are the major ones that are attached to septic shock, is vasopressors, norepinephrine, also known as Levophed, dobutamine, and antibiotics. We know blood cultures are going to be huge. We know monitoring temps is important, and also monitoring that blood glucose. We know when we're going through a huge inflammatory response and a stress response, what gets elevated is cortisol, and then what can elevate our and cortisol can elevate our glucose levels. Okay, so it's very important to keep in mind we don't think about blood glucose like that, but that can most certainly happen in a lot of shock states. So here's a picture depicting the leg raise, and a lot of providers will do this to see if it's a quick way to determine, especially if we don't have the invasive hemodynamics hooked up yet on the patient, if the patient will be responsive to fluids or not, or are they going to need more of like a medication scenario to keep their blood pressures up. So if you see the picture on the left, they're sitting in, it's like a semi-Fowler's position or semi-recumbent position, however you want to call it. And what happens when we do the passive leg raise is we lay the patient flat and we lift the legs up. So this is done by, typically we'll lay the patient down and just lift their legs up with our arms. This picture is showing that they can lift the legs up with the bed. So either or is fine. It's just quicker to do it with your arms and just kind of use a manual mode. And we're going to raise the legs to a 45-degree angle. And what we want to see is that we're going to have that transient increase of fluid volume. So all that fluid that's kind of in the trunk and in the legs is going to kind of come back, and it's going to, come back to the heart, and we're going to hopefully see that our body is going to respond well to that transient fluid volume. Typically it's about 150 to 500 mLs kind of rushing back. And we would hope to see an increase in blood pressure when that happens. So we would recycle the blood pressure within about that minute. And if we were to see an increase, and if it helped and it showed that we had a little bit better cardiac output, if we had a little bit better perfusion by doing that, then yes, we can try some more fluids on that patient. If we did not see any increase in blood pressure at all, we know we're probably going to need more of like a vasopressor medication scenario for this patient. So we hope to see high hemodynamics get better with the passive leg raise by the fluid coming back to the core, to the heart, and it would increase the blood pressure. So I'm just going to talk a little bit quickly about the sepsis flow sheet. We're going to review that. So I know we all had this last semester, and we talked a lot about this with pneumonia. But we know that this is a very helpful tool for nurses to use, especially if they feel like their patient needs a little higher level of care, okay, or just a different treatment scenario. So we know the first, scenario, they need to rule in for at least 2 to move on the sepsis flow sheet. So I know that's, they look at the fever, they look at the heart rate, they look at the respiratory rate. So if we rule in with at least 2 different types of symptoms, we can move on, okay? We know from the sepsis flow sheet that blood cultures are extremely important. Do we want to take blood cultures before we give antibiotics or after? Definitely before, right? We need those cultures before. If we give antibiotics prior, it's going to mess up that culture and sensitivity. We're not really going to know how to treat that patient. So that's why it's so important to do that. So blood cultures are very, very important and should be immediate when we're in any type of scenario with sepsis going on. Antibiotics should be hung within the first hour of symptom onset. That's how quick these patients should be treated. Their mortality rate increases per hour. If every hour they do not receive an antibiotic, their mortality rate increases largely by the hour. So that's how important antibiotics are. And also we know from the sepsis flow sheet that venous lactates are extremely important. We know the level, if they're above 2, we need to retake venous lactates every 2 hours, okay, until they fall below 2.0. We know a huge way to hopefully bring venous lactates down and also help our blood pressure is what? Fluids, okay? So early administration of fluids, early administration of antibiotics, keeping an eye on those venous lactates, drawing them every 2 hours. Those 3 scenarios are huge and so important. I can't drill this into enough of making sure that the patient has adequate fluid resuscitation, making sure that they have that antibiotic very, very quickly within the first hour of symptom onset. If not, their mortality rate increases by the hour. So every hour they do not have an antibiotic, their chance of dying at least increases by 20% by hour. It's huge. It's huge. And keeping track of those venous lactates Q2, because that means that if our venous lactate is decreasing, it means that we're going to have better perfusion. So we have better oxygenation, we have better perfusion to our tissues, right? So that's showing us how well their tissues are perfusing. The higher the venous lactate goes, the more it's showing us of how ischemic and how much breakdown their organs and tissues are doing. And we know fluids, of course, we do that 30 mLs per kg, dependent on their weight. Typically, we are giving those 1 liter boluses. Of course, we need to always be cognizant, what their history is. Do they have CHF? Are they becoming fluid overloaded? But aside from that, yes, they most certainly do need fluids. Just a little story, a little background story of what, something that opened my eyes, that sepsis can be affected in any type of age and how important it is to monitor for sepsis. This was about 8 years ago now. Of course, I was working on critical care. I had just come back from maternity leave with my first son, and a patient was coming up to me due to a MET team on the mother baby unit. That's what it was called then. I know it's called the family birthplace now. And I was like, wow, we don't really typically get, maternity cases a lot. I wasn't sure what I was getting. I know the backstory is that the mom had a C-section about 2 days ago, wasn't feeling well, and that she is coming to us because she was showing, that she was in a sepsis type of state. Everything happened so quickly. By the time she got to me, she was unresponsive. She was needing an airway, and what we call, she was maxed out on all 4 pressors. So she was maxed out on medications that was keeping her blood pressure up to the highest extent. She was only 24. Beautiful, healthy baby boy, 8 pounds, I remember. So on the maternity unit, I know she was just complaining that she had abdominal pain. And of course, if, when they just have a C-section, a lot of it is chalked up to the surgery. But unfortunately, by the time she got to me, it was a little bit too late. And we had transferred her out. I had to go on a trip with her to Mass General. And actually, a physician from the ICU and intensivist went with me in the ambulance. Unfortunately, we lost this patient upon arrival. And it's something I'll never forget. I know that this story is really not the easiest to tell over voiceover. I wish it was in person, because it would just kind of hit a little bit harder. But if there's anything that you take away from this, is just to please know that this doesn't matter what age. It doesn't matter if you're young and healthy, if you're old, a little frail, and have comorbidities. Sepsis is going to attack everybody in the same way, and everyone needs to be treated in the same way and aggressively treated. It's not a joke. It's not something that we can chalk up and say, it's just pain, or, it's something that needs to be monitored. It needs to be checked. We need to do labs, and it's nothing that's worth losing a 24-year-old mom over and changing the family's life totally. So if anything sticks with you, please, please, please always, try to stick to that sepsis flow sheet. Use it to your greatest advantage. And I think you have the knowledge to know that early administration of antibiotics, early fluid resuscitation can most certainly save a life, and keeping an eye on those venous lactates. All right, so here's some diagnostics, and I know we talked a lot about these already, but still good to go over. So we know we're going to be monitoring white blood cells, right? And we see that in our CBC. If we take a complete blood count, or that lavender tube, we're going to see that white blood cell. They can present with leukocytosis or leukopenia. So that can be increased or actually below the range level as well. We may see a decrease in platelets. We're going to see that increase in venous lactate, and we know that number 2.0 and above, they are most certainly going into shock or showing signs that they're in a septic shock. And we monitor venous lactate in every type of shocky state, right? Because we know that venous lactate is in response to that decreased perfusion and that tissue breakdown, okay, because they're having ischemia. We're going to see that increase in blood glucose because our cortisol levels are spiked because of our stress response. Procalcitonin. So this is a lab value that can show an increase in sepsis, or if they're, having any bacterial infection going on. Positive blood cultures will, of course, show that we have some microorganism invasion, and that's going to help us treat with antibiotics, whether they need a broad spectrum or narrow spectrum antibiotic. And we can also get that CRP, so that C-reactive protein, that's our inflammatory marker. And of course, that would be elevated because we have that huge inflammatory response going on. So guys, you made it to the last type of shocky state we're going to go over today. Thanks for hanging on for the ride so far. Obstructive shock. Okay, and we're going to talk about that in the next few slides. All right, so obstructive shock. It's pretty much the term. That's right in it. Something's obstructing. So this develops when there's a physical obstruction to blood flow. So kind of think about that in your mind. You're like, okay, what can cause a physical obstruction to blood flow? When we have an obstruction to blood flow, what do you think is going to happen to our cardiac output? Is it going to increase or decrease? It's going to most certainly decrease, right? We're going to have a decrease in cardiac output, very similar to almost every other shock state we've gone over today. Yeah, we'll have a decrease in preload. Is it something I want you to really worry about? No, I don't. I want you to care more about the cardiac output. So what's going on is there's a, restricted diastolic filling, okay, of the right ventricle from compression. So if you think about that, okay, you're like, all right, so the right ventricle is working hard for some reason. Does that sound familiar at all to anything you've learned so far? Our right ventricle is working hard. Right ventricular heart strain. I wonder what that was from. Okay. So here are some causes for obstructive shock, and it could be that cardiac tamponade. And we know that that's when there's fluid that kind of comes in that pericardial sac, so fluid that forms around the heart, causing a restriction to that filling and also to the pumping. So the filling and pumping action is really, really affected because of the fluid that's causing so much pressure on the heart. So we're not getting that proper cardiac output because of it's almost that fluid is almost like a squeezing mechanism around the heart. So it's creating a lot of tension on the heart. We talked about tension pneumos. Remember, that's when we get that positive air in our lung, and it causes so much pressure that it causes shifting of our mediastinal structures. It causes compression of our heart. So our pulmonary, a cardiopulmonary area is going to be hugely restricted due to the positive air pressure, putting such an amount of pressure on our heart and mediastinal structures. And this is the one we see that tracheal deviation a lot with. Okay, so that, for example, again, if I have that a lot of air, okay, in the right side of my lung, so I have a tension pneumo on the right side of my lung, I'm going to have so much pressure pushing to the left side. So my mediastinal structures and my heart is all going to be pushing to the left. And also I'm going to have that, if you look at your trachea, we're going to see some deviation. We're going to even see some pushing of your trachea to the left side. So it's very, very emergent. PE, okay, I'm hoping you guys are thinking that if you heard right ventricular heart strain, you're thinking that a lot of the right ventricle is causing a lot of restriction because it's working harder. That's a PE for you. So that's also causing a complete physical obstruction of blood flow, causing your cardiac output to deplete and fall. Also, abdominal compartment syndrome. There's so much pressure in your abdominal area, it's actually causing pressure and causing an obstruction to your heart and blood flow. Okay. So here is our little flow sheet. We have some sort of structural compression. Is it a PE? Is it abdominal compartment syndrome? Do we have tension pneumo going on? Cardiac tamponade. So because of whatever compression is going on, whatever force is causing a compression to deplete cardiac output, we're going to, of course, have decreased venous return, decreased cardiac output. And in turn, if we all have that same last three markers, we're going to have that decreased oxygen supply, which means our tissue perfusion is going to be little to none. And we're going to have that impaired cellular metabolism. All right, so how do these patients present with obstructive shock? It's going to be the same, except, the only difference is neurogenic, right? We're going to be tachycardic. We're going to be hypotensive, okay? We're going to have a high heart rate, low blood pressure. We're going to be tachypnic, right? Our body is going to try to compensate. So we're going to hyperventilate. We're going to try to overbreathe. And our body's trying to fix itself right now. Shortness of breath, decreased urinary output. And we know our perfusion to our kidneys is becoming a little to none. The patient may look pale, feel cool, clammy. If our brain is being affected, of course, we know that's the first organ to always be affected by decreased perfusion. We're going to see some agitation, confusion, altered mental status, anxiety. And here's that paralytic ileus, decreased or absent bowel sounds. So how can we fix these patients? How do we treat these patients? Here's our nursing care. Here's our top 3. Patent airway, providing supplemental O2, whether it be lowest from nasal cannula or do they need the highest mode of care of mechanical ventilation. And like I said, it can be anywhere in between. Hemodynamic management. We need to restore circulation. We need to find the cause. What is causing the obstruction? Okay, we need to get down to the cause, fix it, and that's going to bring back our cardiac output and perfusion. So restoring circulation. Fluid resuscitation, yes, that can provide temporary improvement. It can help hemodynamics for sure, but we need to get down to the problem. If we don't fix the problem, the patient isn't going to get better. So if we're thinking about a cardiac tamponade, right? So we have that fluid in the pericardial sac, okay? We have too much fluid and it's causing compression of the heart. So because we have so much fluid, it's almost acting like a tourniquet on our heart and creating like a decreased pumping action and decreased filling action. So we need to get rid of some of that fluid, right? So a pericardiocentesis, it's pretty much like a needle decompression in our pericardial area, removing the fluid and taking off that tourniquet of the heart. Okay, and then that's going to bring back that proper pumping action, proper filling action. We're going to regain our cardiac output and hopefully regain our perfusion to the rest of our tissues of our body. Kind of same thought for tension pneumo. We need either a needle decompression or a chest tube. We need to promote negative pressure back in our lung, right? If we're having so much of that positive pressure because of the tension pneumo, it's pushing all those structures, the mediastinal structures, our trachea, over to the opposite side of where we have that positive pressure. So if we get rid of that positive pressure by either a needle decompression or a chest tube, we're going to we're going to reinflate our lung. We're going to instill negative pressure back. We're going to take pressure off our heart and our mediastinal structures. And then here is our, we're going to regain cardiac output, regain perfusion, regain venous return. If we're talking about, a PE, we of course would want to treat with medications, whether, do they get the TPA or heparin, or do they need a full embolectomy? Okay, do they need clot retrieval, like we saw with that video, with that big clot in the lung? So that depends on the severity of the PE. But again, once we remove that PE that's causing the obstruction, we're going to get our cardiac output back, our tissue perfusion will be better, and our venous return will be better. All right, so congratulations, you just learned all the different types of shock, and there's a lot. It's a lot to take in, but hopefully you're kind of grasping the thought process of how important oxygenation is into our tissues and how every shock state is affected by perfusion. So next we're going to go through the stages. So every type of shock can be in any sort of these stages. All right. There's the initial stage, there's the compensatory stage, progressive stage, and refractory. We really aren't going to talk too much about initial stage because it's typically not clinically apparent. We're going to have some start of metabolism changes, but that's more of like at a cellular level, where the aerobic is moving to anaerobic. and it's really causing that first initial start of buildup of venous lactate. But we really don't see anything going on in the initial stage. It's kind of more behind the scenes. So we're really going to start on the next slide with what the compensatory stage is. Okay, guys, so this compensatory stage is stuff that we're starting to see clinically. Okay, they're showing signs and symptoms now. And really, compensatory is pretty much what it's saying. Our body is starting to compensate because it recognizes that we have a major problem going on, whether it's cardiogenic, whether it's neurogenic, whether it's hypovolemic, whether it's septic. Okay. So it's starting to recognize that we have a problem here. Our body is activating compensatory mechanisms. And if you remember last semester with our ABGs, if we were to draw an ABG, it probably would be showing that we're compensating. It's showing compensation, whether it be partial or complete compensation. Okay. So our body's recognizing that we're starting to hypoperfuse. We're not gathering enough oxygen, as much oxygen as we need to our tissues, and our body is starting to react to that. So, neurostatus, yeah, they'll probably still be alert and oriented. They may show some beginning stages of restlessness and confusion, but it's not going to be really severe neurologically. You might see some changes, some altered mental status changes, but very minor. Our body kind of starts to release on its own, kind of its own hormones, are releasing our own epinephrine and norepinephrine, and our body's going to start to try to vasoconstrict. Okay. Why do we start to vasoconstrict? Especially if we know most of our problems in all Shockey states, we vasodilate, meaning that we have poor perfusion. Remember, we talked about the tube ride with the water ride with the smaller diameter tube, or the smaller diameter plastic tube, or the larger diameter plastic tube. Which one do you go through faster? Typically, it's the smaller diameter, right? So our body's recognizing that when all these Shockey states, we vasodilate. So we want to our body's trying to compensate and vasoconstrict to create better perfusion pathways. Okay. Our heart rate increases because it's a compensatory mechanism, and our blood pressure does start to decrease. That's our classic sign. Okay. That's just because of our decreased cardiac output is starting to happen. Our blood pressure starts to decrease. Okay. And really what is going on is that our body's kind of trying to attract most of the perfusion to our core, meaning that our important organs, our heart and our brain. So our body's pretty smart, and it knows to kind of send more of the perfusion of what we need for oxygenation to our heart and our brain. We may see some decreased blood flow to the lungs. So what's going to happen first? Are we going to overbreathe, or are we going to underbreathe? So are we going to be hyperventilating or hypoventilating in our compensatory stage? We're going to be tachypnic. We're going to overbreathe, and that's a compensatory mechanism. So if we were to take an ABG, we would be in a respiratory alkalosis or acidosis. A respiratory alkalosis, because we are overbreathing, we're hyperventilating. If we, in the later stages, what we'll talk about, when we start to underbreathe and our body is starting to poop out, we're going to hypoventilate, and that's where we would see that we would be in a respiratory acidosis. So we're tachypnic. We're going to see a start of a decrease in GI motility. Our gut's not as important as our heart and our brain, right? So we're going to probably start to see some signs of not so much of a paralytic ileus, but more hypoactive bowel sounds, very far and few between bowel sounds. We'll see a little bit of decrease in renal blood flow, renal perfusion, meaning our urine output may start to decrease a little bit. We may start to appear more pale, cool. In a lot of the earlier stages, remember we talked about, because of that initial vasodilation, we may become warm and flushed. So those are those initial stages, and as we get worse, we're going to become more cool and mottled as we go through the stages. Our temperature may still be normal. It may be starting to change ever so slightly. Okay, so we're compensating on every level here. All right, so hopefully we fix the patient in the compensatory stage. That's our hope. That would be best, most ideal for us, because we can easily get patients hopefully back to normal from the compensatory stage. But yes, they can progress to the progressive stage, meaning they're getting worse. Okay, the main thing that splits apart the compensatory stage to the progressive stage is they have a major change in mental status. Okay, we're now seeing a huge decrease in cerebral perfusion and cerebral blood flow, meaning that their responsiveness is going to be not good, right? So it's going to be very, very low. They're going to have altered mental status. They're going to have decreased responsiveness. They may start to get very lethargic, delirious. And also big change in this stage from compensatory to progressive is we have a huge increase in capillary permeability. So this is a stage, what this means is that this is a stage where we're going to start to become leaky, right? We're going to start to have the third spacing. We have an increase in capillary permeability, meaning our fluid is coming out into our extravascular space and it's leaving our intravascular space where we need it to be. So we're going to really lose our blood pressure at this point, and we're going to become anosarchic, edematous. We're going to have fluid in spaces where we don't want it to be, and it's not going to be helpful for us, okay? We're going to have that continued decrease in blood pressure, a continued increase in heart rate, and a lot of that has to do with the loss of fluid coming out of our intravascular space. A continued decrease in perfusion, meaning that we're going to hypoperfuse all of our tissues, all of our organs. Our tissues are going to start to become ischemic. We may run into dysrhythmias at this point due to decreased coronary perfusion, possible MIs due to decreased coronary perfusion. Also decreased peripheral perfusion, okay? You know, that means our tissues, our organs are not getting properly perfused. This is a stage where we start to enter ARDS, acute respiratory distress syndrome, okay? Especially think about it, we have that huge inflammatory response and we have a huge increase in capillary permeability. So what's our lungs going to fill with? Fluid. We're going to have that third spacing right into our lung space. So remember we talked about those lovely alveoli, and those are the little air sacs that all that goes on in that area is really gas exchange, right? We have gas exchange going on in our alveoli. And if we have a huge rush of fluid into our lungs, are those going to become weighted down, or do you think they're still going to become inflated? Those are going to get weighted down with edema, fluid. You think we're going to have good gas exchange going on in our lungs? Not at all, okay? So we're going to enter a stage that is, we're going to talk about ARDS a little bit later in the semester, but this is huge pulmonary and alveolar edema. And this is a major problem. This is typically when patients really need critical care. They need to be intubated and on a ventilator. We're going to start to see an ischemic gut, okay? We're going to start to see erosive ulcers. We're going to start to see GI bleeding. We have a paralytic ileus. We have hardly any perfusion going on to our gut because really it's not as important as our heart and our brain. But what happens when we don't have proper oxygenation and perfusion to our gut is we end up with ulcers, we end up with GI bleeding and an ischemic gut, okay? Renal tubules, they become necrotic. Acute tubular necrosis, ATN. So is our urine output going to be good or is it going to be bad? It's going to be bad. We're going to see a huge progressive turn on decreased urinary output. We may not see any urinary output at all. Our liver becomes affected, right? Okay, decreased perfusion to our liver, decreased oxygen to our liver. We may see patients become jaundice. Do you think they'll be able to metabolize drugs and waste as good as they usually do without that good perfusion? No, not at all. We may see some increased liver enzymes on our labs. This is kind of where we start to see that DIC, disseminated intravascular coagulation. So that's when our body consumes platelets and clotting factors. And when our liver finally becomes affected due to decreased perfusion, our liver is our main coagulopathy organ, right? It helps our coagulopathies, it helps us clot, it helps our bleeding factors. So when that gets injured, we're not going to have much control over our bleeding. So this is a lot of times that patients start to bleed out, okay? And this is a start of DIC. The progressive stage is the start of disseminated intravascular coagulation. That is as far as I want you to get with DIC, okay, in this content. Just know that our liver becomes affected, our liver becomes poorly perfused and oxygenated, and it's going to affect our clotting factors in our liver, and we're going to start to bleed out of some orifices. So that is very typical to see in the progressive stage, and that's as far as I want you to know what goes on with DIC, disseminated intravascular coagulation, okay? Skin is going to be cold and clammy, and we may be hypo or hyperthermic, depending on the body's temperature. That can go either way still at this stage. And then our refractory stage, a stage we really don't want our patients to be in, a stage that is hard to really get patients out of. We see high mortality rates if we enter the refractory stage. This is the last stage of shock. Unfortunately, these stages don't get better, they get worse. So now neurologically, our patient is completely unresponsive. They have little to no neurological response. They may have total loss of reflexes at this point. If you're doing your pupillary check, which I hope you are, remember we talked about those really detailed head-to-toe assessments, you may notice the pupils will become non-reactive and dilated. The patient remains in profound hypotension, no matter how much fluids you're giving them, no matter how many vasopressors you're giving them, okay? Now, we are totally out of compensation. So instead of being tachycardic, we are now going to be bradycardic, okay? Our body's pooping out. It's not going to fight anymore, and it's not going to maintain that tachycardia. Our heart's not going to keep up much longer. So now you're going to notice if we reach the refractory stage, you're now going to notice your patient's going to be brady, and that's the really main determiner of the refractory stage. Bradycardic, the heart rate is also going to be irregular. We're going to now be hypoventilating, okay? So our body also is pooping out respiratory wise, and they're not going to be overbreathing, they're going to be underbreathing, meaning if we take an ABG, we're going to be in a respiratory acidosis instead of an alkalosis. Total ischemic gut, we're still going to have erosive ulcers, we may still have GI bleeding going on. Patient is still going to be anuric. They're not going to make any urine whatsoever in this stage. We're going to see huge metabolic changes. Our liver is decompensating and pretty much is ischemic. So we're still going to see DIC progressing. Our patient is going to start to bleed out of multiple orifices in their body, total accumulation of waste from the liver. They're not going to be able to metabolize much drugs that they're receiving. The patient is going to be hypothermic, and the skin is going to look mottled and cyanotic. If you were to take venous lactates at this level, they're going to be like super high. The highest I've ever seen was actually 26, a venous lactate at 26, which is pretty much almost irreversible at this point. And they're in a complete total acidosis. So just overall diagnostic lab studies for shock in general. A lot of this may be redundancy, but redundancy is good, right? That's how you learn. So first off, ABGs, we talked a lot about those. Please know, like if you were to get a question be asked in the earlier stages, like a compensatory stage, what might you see as an ABG? And that would be respiratory alkalosis. And in the later stages where we're not compensating anymore, we'll probably see a respiratory acidosis. We're not overbreathing anymore. Our body is starting to poop out. Blood cultures, especially for septic shock, right? We're going to get blood cultures, see the growth of organisms, so we know how to properly treat the patient. BUN and creatinine, with every type of shock, we know that we're going to have some sort of decreased perfusion to our kidneys, so we'll probably see decreased urine output, and we may see increased BUN and creatinine. CPKs would be increased, creatinine kinase. That's a cardiac biomarker, okay? So we may see that due to injury or ischemia going on or trauma to the heart, any cellular damage due to hypoxia, we would see an increase. And also, we could do /troponin, okay? So creatinine kinase, CPKs, or troponins would show that there's injury going on to the heart due to hypoxia and ischemia. When our liver starts to get affected, we have decreased perfusion to our liver, meaning that our coagulopathies are going to be totally askew. We can do a DIC screen, meaning that we can get fibrinogen levels, platelet count, PTT, PT-INRs, thrombin times, D-dimers. So just doing that DIC screen, especially if we start to know if we're in the refractory stages or in the progressive stages, if we're starting to enter DIC. Glucose is going to be elevated, and why is that? It's in response to the release of cortisol, right? So we're having a stressful situation in all different types of shock. Okay, our stress is increased, meaning our cortisol is going to increase, meaning that our insulin is going to be insensitive, and we're going to have high glucose levels. Venous lactates, those are going to be increased. Why is our venous lactates going to be increased? We're hypoperfusing. So when we have hypoperfusion to our cells, to our organs, to the rest of our body, that's starting to form that anaerobic metabolism, right? And it's starting to break down our tissues. They become ischemic. And what's left off is that lactic acid, meaning that a venous lactate level is going to pick up the release of that lactic acid from the breakdown due to hyperperfusion. So that's why those venous lactates are going to be elevated, and they're such an important lab draw for every different type of shock. Liver enzymes, especially if our liver is starting to decompensate and become hypoperfused, liver cell destruction and ischemia, those will be elevated. Procalcitonin, we talked a little bit about that with septic shock, and that's released in a response to a bacterial infection. So a lot of times if patients have any sign of sepsis, a procalcitonin will be drawn. So when you're in your clinicals, look at your labs and see if a procalcitonin has been drawn, especially in a patient who's had some sort of infection. I'd be curious to see if they're really drawing them. They're really best practice. It's newer to the healthcare community, procalcitonins. A lot of research has been done on them, and it shows that they're a great early marker to try to help prevent sepsis from happening. White blood cells, they could be elevated or that they could be lower, right? Leukopenia or leukocytosis. So either way. And we talked about troponins, just like the CPK, right? All right, so nursing management, we're kind of starting off in the emergent stages of management here. So this is kind of the early recognition, the prompt intervention, and identifying that your patient's at risk. And hopefully we're identifying this early and we're catching them in the early stages of shock and hopefully not letting them slip into the progressive stage and or the refractory stage that we just went over. So kind of similar to burns, if the patient is unresponsive, of course, we're going to do CAB, circulation, airway, breathing. And if unresponsive, we're going to definitely go with airway, breathing, circulation, the ABCs. So very, very similar thought to what we were taught in burns. If there is any issues with trauma, especially if there was a fall or we think that there is any cervical injury, stabilize the cervical spine, and we need to make sure the patient is in C-spine precautions until they are cleared, right? So maintaining them in the neck collar, on the hard board, log rolling, okay? If there's any external bleeding, okay, if there's any hemorrhaging, making sure we apply direct pressure. Anticipate any need for intubation and mechanical ventilation, okay? Always assessing their airway. 2 large bore IVs, okay? That's kind of, that's basic stuff. If we can get more, yes, that's the better, but at least 2 large bore IVs in this patient. If we cannot get an IV in, especially if the patient has gone through a significant amount of trauma or, they've been in a hypovolemic shock for some time, we may not be able to find an access. So we may need to get an intraosseous, also known as an IO. Patient may need central line, so aiding in central line insertions. Beginning fluid resuscitation. All these shocky states will at least need some sort of fluid resuscitation. Some are more aggressive than others, especially like the hypovolemic would be a little bit more aggressive. We know septic would be a little bit more aggressive. So that would be normal saline or lactated ringers, 30 mLs per kg, very similar to the sepsis protocol. Drawing labs, those are all the labs we went over. Okay, getting a whole rainbow of labs, especially all the diagnostic labs we went over on the last slide. If we are not fixing their blood pressure with fluids, we're going to need to consider vasopressor support, and we're going to go over all the vasopressors in a bit. So if hemodynamics are not getting better with fluids, vasopressors would be the next step. Foley caths, we need to know strict diagnose, right? Okay, we need to see if what's coming in is coming out, how are our kidneys functioning, and of course, if our kidneys are not functioning properly and they are hypoperfused, once we start seeing some perfusion, we're going to want to see an increase in urinary output, and we'll also see that via the Foley cath. Starting antibiotic therapy as soon as possible, especially if it is septic shock, right? Monitoring EKG rhythms. So we're going to dig a little bit deeper into fluid resuscitation and look at the different type of products that we can use. And fluid decisions, they're based on the type of volume or fluid that has been lost. How's the clinical, how's their status? How's the patient's status? And how much fluids do they need, and what type of therapy will they need? Typically, normal saline is the initial fluid used in resuscitation. We see that all the time. I know more with like surgical patients, and especially at BMC, they tend to like lactated ringers a little bit more. So you'll see different physicians like different types of things. But we're going to go over crystalloids here. So crystalloids, isotonic solutions, that's your normal saline and your lactated ringers. The nice thing about this type of solution is it stays in the intravascular space. That's where we want it to be, right? And it's increasing our intravascular volume, meaning that it's going to hopefully correct the low blood pressure that we're experiencing. So that's our initial volume replacement. Some things to monitor for, especially for giving high volumes of normal saline, is probably sodium, right? We want to just be careful with that, but we want to make sure that we get the patient out of that critical state first, and then we'll take a look at our electrolytes after. Also being careful with lactated ringers. High volumes of LR can cause your serum venous lactate level to increase. So just keep that in the back of your mind, that may happen, but that's large amounts of lactated ringers. Blood products, they're very, very helpful. Not only can they help replace blood, but if we are hypoperfused and we're not getting the good supply of oxygen, blood carries oxygen, right? So if we feel that we're hypoperfusing and the patient may not need blood, but a lot of providers may choose to give blood just because of the oxygen content in it. So that's always interesting. I have had a few patients that I've given blood, they've necessarily haven't needed it, more so needed it for the oxygen therapy. But blood products are packed red blood cells. Typically, it's like a 350 ml bag of volume. So, of course, it's going to replace blood loss, and we'll see that a lot with hypovolemic shock. And, of course, increases the oxygen carrying capability, just what I have mentioned. Fresh frozen plasma, also known as FFP, that replaces coagulation factors. So something to think about, especially if we're entering the progressive phase, where we're seeing a little bit of start of DIC, disseminated intravascular coagulation. That may help a bit of coagulopathies and help our clotting factors a little bit, so we can hopefully stop the bleeding that the patient is going through for DIC. And then platelets. This can also help control bleeding, especially caused by thrombocytopenia. So platelets, FFP, can most certainly help, especially if our liver is losing its function, it's becoming ischemic and hypoperfused, and we're entering the DIC. FFP and platelets can be very, very helpful. And then colloids. This is a very helpful drug. Albumin is wonderful because it helps with rapid volume expansion. So albumin is known, it's like our star player in helping pull fluid back from the extravascular space back into the intravascular space, back where we want it to be. It has that osmotic effect and it has that pulling effect. So it's very, very helpful in patients with hypovolemia, especially with burn patients. Liver failure patients, it is very, very helpful with as well. This is not to be used in cardiogenic or neurogenic shock. Okay. And typically the solution type, albumin is typically 5%. We use that, that's the most common, 5% of albumin. I've never given 25% albumin, but this is especially for patients who may have more of a sodium restricted or fluid restriction. So it's a little bit more heavy in content, but not as much fluid, if that makes any sense. So our goal for fluid resuscitation is to restore our perfusion, okay? No matter what's going on. Where we're losing our volume, are we pulling our volume back from the extravascular back into the intravascular? Our blood pressure is a great determiner if our fluids are working, whether it's blood products, colloids, or crystalloids. So we can see that a lot in our hemodynamics. And again, how do we monitor for fluid responsiveness? Like I just said, hemodynamics, vital signs, that's going to kind of be your number one. How did our oxygenation improve? How's their skin look? Is it, how's their temperature? Did their urine output increase? Okay, so a lot of assessment is going on. Warming these fluids can help prevent hypothermia, especially if they're getting large amounts of them. So that's always something to keep in mind, especially if we're using the rapid transfuser. It has a warming system within it itself, so it warms the fluids already. If they're getting products via a central line, they really should be warmed as well. That's best practice to do that for. Okay, so this is our drug therapy. This is where we're going to concentrate mainly on the drugs here. So dobutamine, this is our first vasopressor, and this is used in cardiogenic shock. It can also be used in septic shock to help increase oxygen delivery. Is it a number one choice for septic shock? No, it is not. It can be used. Do I see it used a lot? No, I don't. We don't typically see dobutamine or dopamine used a whole heck of a lot, but they are still available drugs and they are vasopressors. So dobutamine, it's specifically used for cardiogenic shock. That's what I mainly want you to focus on for it. It helps increase cardiac output, like we mentioned while we were in cardiogenic shock, and it also helps myocardial contractility. So it helps with the filling, it helps with the pumping mechanisms, it helps increase cardiac output. All vasopressors should be given via a central line. So dobutamine should be given via a central line. Keep in mind, hypotension may worsen, so the patient may need a second vasopressor added on if it is causing hypotension. Dopamine, also used in cardiogenic shock, also helps increase myocardial contractility, helps increase cardiac output, helps with blood pressure, helps increase heart rate. This is one, dopamine, to monitor for tachydysrhythmias. I have given this medication not that long ago. We had a patient arrest at home. The significant other was not able to do CPR as they were in a wheelchair, I believe. So the patient was down for some amount of time. We did the cooling when patients are not responsive post-arrest. We do cool patients, a hypothermia protocol, because we hope to regain brain function, especially if the patient has been down. Dopamine was ordered as this patient was in a cardiogenic shock, and I experienced this. So we monitored for tachydysrhythmias. Really what happened is this patient went into what was called a they went into a fast VTach with a pulse. but they also entered a torsades, and that it was almost immediate. The patient was not on the medication more than 2 minutes, and they went into a torsades rhythm, and quickly went out. But it was, to see it in person, it really makes you remember the medication. It really does. So dopamine, monitor for tachydysrhythmias. Hopefully with that story you'll remember that. It can cause peripheral vasoconstriction. Okay. And what that means is vasoconstriction, meaning your vessels are constricting, right? And we're going to monitor for how our CSMs are doing. A lot of vasopressors, what you'll hear nurses say is it clamps patients down. So really what happens with peripheral vasoconstriction and with clamping down, it's pushing all the blood to the patient's core where the patient needs it the most, to the heart. So when we hear peripheral vasoconstriction, or a nurse may say vasopressors are causing clamping down, the patient's clamping down, that means that their blood is being taken from their peripherals, from the non-important organs, and pushing the blood to the heart. Okay, so that's really the act of peripheral vasoconstriction, and that's why we monitor CSMs, circulation, sensation, and movement, just to make sure patients aren't, that's why we want to get patients off vasopressors. We don't want them on vasopressors long term, because it can cause organ deterioration, it can cause tissue deterioration, especially the clamping down, right? Next, we have epinephrine. This is a common drug. It's a common vasopressor. It can be used in cardiogenic shock. Anaphylactic is huge, right? We know epi is our #1 drug of choice for anaphylaxis. That's what's going to help them get out of anaphylactic shock. And it can also be used in septic shock. It really helps increase heart rate. It helps increase cardiac output, and it helps the heart's contractility. If this can be given IV push, especially if the patient is in a cardiac arrest. It can also be given IV push in anaphylactic shock. This can be given IM in anaphylactic shock, or it can be given in a continuous IV drip if the patient is hypotensive. So a few, different ways and routes that this can be given. If it is given via a continuous drip, it of course needs a central line. There's just two different types. So I know you heard me mention there's an IV push type for if a patient's in cardiac arrest. Epi is given. That's an A adrenergic. If this is given more over a continuous drip, so a little bit more long term, that's a B adrenergic epinephrine. Okay, so a little bit different in types. But the big thing is to monitor for heart rate. It can really skyjack a patient's heart rate. So monitor for tachydysrhythmias, monitor for shortness of breath. A patient may have some chest pain, and just be on high alert for any renal failure. Norepinephrine, this is like your go-to. This is your go-to vasopressor. This is pretty much #1 for a lot of shocky states, especially if we're in septic shock. This is your #1 drug of choice for septic shock is Levophed, also known as norepinephrine. It can also be used in cardiogenic shock. I know dopamine and dobutamine are your drug of choice for cardiogenic. It's a cardiac stimulator. It helps increase blood pressure, and it helps increase cardiac output. So this is your #1. If fluid resuscitation is not working, we go to Levophed, okay, or also known as norepinephrine. It's a peripheral vasoconstrictor again, so that means we're going to be clamping down our peripherals. We're not going to have as much blood flow to our peripherals as we are to our core and to our heart. But it's doing that to help just keep our patients stable and help increase the blood pressure at that time. Again, that's why we try to titrate vasopressors off as quickly as we can while maintaining the patient's stability. This is also given central line. All these drugs, all these vasopressors are highly vesicant. So they're horrible to the veins. If they were to if the medication were not to go into a vein and it's going under the skin and it's infiltrating, it can cause horrible wounds. It can cause, you know, extravasation. It's not good for the skin. All right, our next vasopressor is phenylephrine, also known as neosynephrine. Aadrenergic. I really don't want you to focus too much on that. I just want you to know the name and what really the helpful cause, what drug belongs to kind of what. This helps increase heart rate and blood pressure. Okay. This is like your number one go-to for neurogenic shock. If there's anything I want you to remember, this is a big one for neurogenic shock, because in neurogenic shock, we experience bradycardia, right? Not only do we experience hypotension, but our patient's bradycardic. So that's going to help with both. An important thing to monitor is reflex bradycardia. Okay, so it's not typical. I've never really seen reflex bradycardia with neosynephrine, but it can happen. Monitor for headache and restlessness, and of course, this is given via central line. This should be our last vasopressor is called vasopressin. This is most often used for septic shock. It's like an antidiuretic hormone, really. And what what vasopressin helps with is really increase our mean arterial pressure, also known as our MAP. It can also help increase urinary output. Helps bring up blood pressure, helps with cardiac output. Please know that this is the only vasopressor that we cannot titrate. It is non-titratable. It runs at a certain rate, and you do not touch it. 0.04 is what vasopressin runs at, and you just let it be. This typically is given as a last vasopressor, especially if the patient is already receiving multiple. Okay. You're like, multiple. So we have patients that enter states that are so unstable that we need to add, we may have epinephrine, we're going to have levofed, we're going to have neosynephrine, and then we're going to add a fourth one on, vasopressin. So a lot of times you'll hear nurses say, well, they're maxed out on pressors. Yeah, they're maxed out on all medications, meaning they've titrated as high as they can on all vasopressors, and hopefully the patient holds stable at that point. If the patient is still not maintaining hemodynamics on all vasopressors, that's when we typically, talk about plan of care, possibly comfort, and we have meetings with the family. So yeah, there's multiple cases that we have patients maxed out on all medications. Going back, you can titrate as high as, we've gone higher, but best practice is to titrate as high as 20 mics on levofed. When we're talking about phenylephrine or neosynephrine, we can go as high as 200 mics. Vasopressin, we do not titrate. That stays at 0.04. And then epinephrine can go as high as 30 mics. So that's how high we can titrate up on each. Do I want you to know that? No, I do not. But I just want you to realize, how high we can titrate. And a lot of times, if you hear maxed out on all pressors, it means that they're at the highest titratable level on all medications. So I think this is really, really interesting. I really want you guys to kind of hone in on this. This is a little bit into advanced cardiac life support, also known as ACLS. But because when we enter shock, we're at such a high risk of cardiac arrest, we always need to know what's called our H's and T's. So this first slide is all the H's. So when our patient goes into cardiac arrest and we're actually really not quite sure of the cause, we know they're in some type of shock, but we're not quite sure how to hone in on it. We have an algorithm, or really, I don't know if I want to call it a mnemonic, but We have H's and T's that we go through and we rule out, especially if we're in a code situation or a MET team situation, and we're really not sure what happened or why the patient ended up coding. So we go by ruling this out. So H's, hypovolemia is our first H. Was there any significant loss of fluid volume in their system? So looking for the obvious blood loss. And what's our most important intervention if we do think that there was a high amount of fluid volume loss? So the first H we talked about is hypovolemia. The second H is hypoxia. Was there any deprivation of inadequate oxygen supply? Could that have contributed to the cardiac arrest? So always ensuring that their airway is open. Is there adequate ventilation? Is there bilateral breath sounds? Ensure that the oxygen supply is connected correctly. Okay. The next H is hydrogen ion. That's the acidosis part, okay? So number one, what does our venous lactate look like? And what does our arterial blood gas look like? Is our patient acidotic and our venous lactates higher than 2.0? So obtaining that ABG, determining are they in some sort of acidosis, providing adequate ventilation to try to help get them out of an acidosis. And a lot of times if they are, sodium bicarbonate is a medication that can be used to help get the patient out of an acidosis if they are. Our fourth H is either hypo or hyperkalemia. We know K is so important to what? Our cardiac system, right? So both a high and low K can cause cardiac arrest. So ruling that out, taking the lab value and looking at the K results. So signs of high potassium could be, we can see this on the EKG. So they can be taller peaked T waves. Is there a widened QRS? Some signs of low K include flattened T waves, prominent U waves, and possibly a widened QRS. So that could be a problem. If we have low amounts of K, we know we need to give potassium, right, via IV piggyback. If we have too much potassium, it means we have to take it off, and that's a medication called K-oxalate. And the patient typically will remove potassium via stool. And our fifth H is hypothermia. Was the patient, exposed to cold weather? Have they been in cold for long amounts of time? What are the warming measures that should be taken? The core temperature should be raised above 86 degrees Fahrenheit as soon as possible. We don't really typically see that a whole heck of a lot. I know a patient has come in falling through the ice. I think a patient was found once, but we don't really see that a lot. So that's our H's. And next we have our T's. So we got to run through our T's too. So T, our number one T is toxins. Was there some sort of accidental overdose? We run through, beta blocker overdose, calcium channel blocker overdose, tricyclates, digoxin overdose. Those are some of the most common. Was it a street drug? Cocaine, most common street drug that increases incidence of pulselessness, for sure. We now see cocaine that is laced with fentanyl. We see that all the time. Some physical signs of a toxin overdose may be bradycardia, pupillary changes, neurological changes. We contact poison control if there's ever been any possible accidental or intentional overdose or a street drug overdose. The poison control center actually gives the physician directives on how we need to treat the patient. Tamponade. So we talked about cardiac tamponade, right? A lot, especially with cardiogenic shock. And what was the other type of shock? Obstructive shock, right? So we talked about cardiac tamponade with two types of shocks, and this results from fluid buildup in the pericardium, which affects pumping. So like we talked about, cardiac tamponade is like a blood pressure cuff or a tourniquet around our heart, and it's affecting our pumping, leading to decreased cardiac output, decreased blood pressure, and of course it can lead to arrest. So if we're noticing any EKG symptoms, especially like on our QRS, might be narrowed. Are we having like a rapid heart rate? Is there any jugular vein distension? Difficulty palpating a pulse? Is there muffled heart sounds is a big one. But what really we need to do is correct the underlying problem, right? So performing a pericardiocentesis, doing a tap to the pericardium to remove the fluid, which and then will remove that tourniquet-like band around the heart so it can pump effectively again. We talked about the tension pneumo, okay, and two different types of shock. So that's cardiogenic and obstructive shock as well. So like we said, we have a huge increase of air in whatever lung, maybe both lungs, but typically it's one side or the other. And all of that pressure is causing actually an intrathoracic shift. It's causing a mediastinal shift. It's causing a tracheal deviation to the other side. And that's putting so much pressure on our heart when we have shifting, and our heart's not going to pump effectively, and of course leads to cardiac death. So again, signs of pressure on the heart is that narrowed QRS and that rapid heart rate. Very, very similar to cardiac tamponade. We're going to see jugular vein distension. We're going to see tracheal deviation. You're going to see unequal breath sounds, difficulty to ventilate. And of course, the patient's going to need needle decompression to get negative pressure back in that lung field. And that's going to take away the pressure and the structural shifting. So it'll take pressure off the heart so it can pump effectively again. Our fourth T is a thrombosis, meaning some sort of clot, right? So it causes is really acute MIs, so STEMIs. That's a big one. So EKG signs, we're going to see ST elevation, right? Remember from last semester, we're going to see that tombstone looking ST elevation. We're going to see elevated troponins. We might see elevated CPKs. So this patient's going to need what emergently? Think of the STEMI protocol. They're going to need fibrinolytics, meaning they're going to need TNK, right? That's our clot buster. And they're going to need PCI, meaning that they're going to need a cardiac cath and they're going to need stenting to the heart to revascularize the patient. And they're going to need the TNK to break up that clot. And our last T is thrombosis, again, meaning PE. Okay, so we talked about MI. We can also have PEs. PEs is part of obstructive shock, right? So it can rapidly lead to respiratory collapse and sudden death. And we learned a lot about that last semester too. We may see a narrow QRS. Patient's going to have that rapid heart rate. A lot of these patients go into that PEA arrest, right? So we'll see, you know, we're going to need that CTA, right? We're going to need that chest CT with contrast. And they're going to need some type of fibrinolytic, meaning they're going to need TPA and heparin. All right, so continued important nursing implications for shock, and a lot of this is probably going to be redundancy, but you know how I like to repeat myself because I know that's how we learn. So ABCs or CAB, one or the other. If the patient's alert and responsive, we're going to follow ABC. If the patient is not and they're unresponsive, we're going to follow CAB. So we're assessing tissue perfusion by all systems, so that's why we do that very detailed head to toe. How are their vital signs? How are their hemodynamics? Going head to toe, what's their level of consciousness? Okay, how's their alertness? How's their responsiveness? How's their CSMs? How's their circulation? How's their sensation? How's their movement? How's their peripheral pulses feel? How's their urinary output? Going very quickly through the systems, right? And we're gonna do this for, in a second. Also, what's happening as the shock progresses, and we want to catch this in the earliest stage possible. We do not want them to progress to the progressive stage. We do not want them to progress to the any further stage. So early recognition is so important. So neuro, right? We're going to start with neuro. We're going to assess level of consciousness. That's our best number one indicator. If I can't say this enough, you may see it. You may see it. Our best indicator of cerebral blood flow, okay, is your neuro assessment. Note changes in behavior. Is there any restlessness going on? Confusion, agitation? That's going to be a huge red flag. Orient the patient on a regular basis, okay? If, you know, reduce light, reduce noise levels. Try to keep this patient on a day-night cycle, okay? Keep them awake during the day if we can, have them sleep at night. Monitoring temperature, whether it's oral or rectally. Cardiac is next, okay? Most therapy done for shock is based on hemodynamics, for sure. Whether we're giving fluids or whether we're giving the blood vasopressor medications we just went over to help keep the blood pressure up, you know, most of this is based off of hemodynamics. Because we're basing fluid and because we're basing titration of medications off hemodynamics, we most likely need to do invasive monitoring because we want to be as specific as we can and get the most accurate blood pressure that we can. So constantly assessing blood pressure and heart rate. And like I said, using this via invasive monitoring, using a central CVP, okay, getting a central venous pressure reading, monitoring the patient's cardiac output invasively, cardiac index, stroke volume variation, monitoring the EKG rhythm, CSMs, fluid administration, giving vasopressors, and titrating them appropriately. Central venous pressure, I want you to know the normal is 0 to 8, okay? If we're on the low side, we probably should be giving fluids. If we're getting up to the 15 to 20 region of a CVP, we're probably maybe a little bit getting too overloaded. So that's when we know that we need to maybe back off on a little bit of fluids for a central venous pressure reading. 12 to 15 is satisfactory, okay? Like I said, getting up into the 20s, we need to back off a little bit. The patient actually may need diuretics to take a little bit more fluid off. You've heard MAP a lot, right? We've talked a little bit about MAP, and you're like, okay, well, MAP. MAP is mean arterial pressure. Mean arterial pressure. If you take your systolic and then you multiply your diastolic by 2, and you add those two numbers together and divide that by 3, that's your MAP. But in today's day and age, we're so lucky. We have our nice, lovely bedside monitors, our Philips monitors, and they give us a MAP level, okay, right next to our blood pressure. So if you see your blood pressure and there's a number in parentheses right next to it, that's your MAP. It's a really great indicator of perfusion to our organs. It's a lovely indicator. We like to see MAP 65 and above, okay? If we're dropping below 65, we're not perfusing as well. A lot of times we typically actually look at the MAP more than we look at our systolic blood pressure when titrating vasopressors. A lot of providers will say follow your MAP, titrate to at least a MAP of 65. So this is really the average pressure in a patient's arteries during one cardiac cycle. So MAP is super important with titrating vasopressors and making sure that we have perfusion to our vital organs. And that's why I wanted to go over that. I just wanted to show you what an arterial line may look like. Arterial lines are lovely. They're very helpful to nurses, and they're used in the critical care unit. It's an invasive line where a line is actually placed in the patient's artery. Typically, we place these lines in the radial or axillary artery. I have seen them in the femoral as well. And they take a direct pressure right from the artery itself. So you know that you're getting the most accurate blood pressure, not via a cuff. So if we're titrating multiple vasopressors, we're going to want that accurate blood pressure, right? So this is how we get our arterial line. It has to be transduced. That is very far into critical care. I just wanted you to see what an arterial line hookup may look like. And it is the blood pressure is transduced to our bedside Philips monitor via a transducer with a pressure bag. Also, arterial lines are lovely, especially if we're getting multiple ABGs. We can just draw blood from the arterial line, and there's our ABG. We give it to our respiratory therapist, and they run it. So it's very lovely. The patient doesn't need to get stuck in the artery multiple times. I just wanted to give you a visual of this as well. This is a monitor we use often in the critical care unit, and it's called a flow track, T-R-A-C, flow track sensor. And this is part of an invasive monitor, and it's actually hooked up through the central venous line. So if a patient has a central line, it is actually transduced right through the central line. This gives us a direct reading of the patient's cardiac index. If you see in the top left corner, it's the number 3.6. So that's cardiac index. It also measures if you look at the top right corner, the number 7. SVV means stroke volume variation. If you look in the bottom left corner, it says SV, and that stands for stroke volume. And if you look at the bottom right corner, we have our SCVO2. So it's central venous oxygen saturation. Pretty neat, huh? So it's your oxygen saturation via your central venous blood. We use this often. And it's a great indicator to the provider on how well our heart is functioning, especially for patients in either a cardiogenic shock or septic shock. It's a great visual. Do I want you to know these numbers? No, I just thought it would be interesting for you to see. So continuing with important nursing implications for shock, pulmonary. Okay, we just got done with cardiac, so ABCs, always monitoring their airway. How's their respiratory rate? How's their O2 sat? How's their work of breathing? Are we correcting any sort of acidosis? Are we correcting any sort of alkalosis? What stage are they in? Are they compensating? Are they in a respiratory alkalosis, or are they decompensating, pooping out? Are they in a respiratory acidosis? A lot of patients, especially, remember we use the term clamping down, and the blood is kind of leaving their peripherals and it's coming to their core just to help our blood pressure and hemodynamics. A lot of times those finger sats and those probes don't work as good, right? I think we've all had patients in clinical already that don't have the best perfusion to their fingers. So sometimes ear probes work very nicely. Nose probes may work as well. So just keep that in mind, especially if the patient is on multiple vasopressors and they're really clamping down. Arterial blood gases, we're going to be constantly monitoring them and always assessing the need for mechanical ventilation and caring for them if they are on a mechanical vent. And that's a little farther down the road in the next few weeks is mechanical vents. Renal, measuring their urine output hourly. We have to get hourly outputs. It's so important. They're going to need a Foley catheter. Urine below 0.5 mils per kg per hour is definitely inadequate renal perfusion. We're always monitoring their BUN and creatinine and seeing how our kidney functions are doing, and that helps us let us know if our kidneys are regaining any perfusion. Also important, emotional support is huge, especially if the patient is in the critical care, right? There's a lot of beeping going on, a lot of noises. The lights are weird sounds. It's pretty traumatic. And I know there's been a lot of studies done recently of how patients actually experience almost like a PTSD after being in the critical care for some time. There are medications to help decrease pain and anxiety, especially if the patient is on a mechanical vent. Yes, they are going to be on some sort of sedation. Providing oral care. Don't forget the skin integrity, guys, right? Range of motion, turning and repositioning. We can never forget the basics. Yes, we're talking about high levels of critical care right now, but we can never forget the basics. Those are really, really, really important. And this is where I kind of want you to stop. This is a lot and this is enough. Like I said, yes, we can go over mods. We've gone over a little bit of DIC. Do I want you to get too crazy on my multi-organ dysfunction and DIC? I don't. Just knowing just the basics here. So really what's going on is that our sepsis has, or excuse me, our shock has progressed, and now we're entering organ failure, right? And that happens, we know this is happening because if we've reached the stage of decreased tissue perfusion and organ perfusion, we're going to probably start ending up with some organ failures going on. So failure of 2 or more organ systems is when patients enter MODS, also known as multiple organ dysfunction syndrome. Homeostasis cannot be maintained without any intervention. We've talked a lot about these interventions. So MODS, it's a result from a systemic inflammatory response syndrome, and it's our body's response to all the different types of shock that we really just talked about. And that's really as far as I want you to get with that. So with MODS, we're trying, in shock in general, we're trying to reperfuse our body the best that we can. We're providing treatments the best we can to try to optimize perfusion, right? So if we're talking about neurologic status, the patient may end up with a hepatic encephalopathy. They may end up with a delirium. They could end up with seizures. So multiple things can be going on due to decreased blood flow and decreased cerebral blood flow. Cardiac, we could end up with a biventricular failure, huge decreases in blood pressure, MAP, mean arterial pressure, cardiac output, a systolic and diastolic dysfunction. We talked all about that with cardiogenic shock. With pulmonary, we talked a lot that our patient can enter ARDS, meaning acute respiratory distress syndrome. We're going to go over that in a few weeks when we talk about vents, but it's very detrimental. ARDS is very horrible, and it's very hard to get a patient corrected once they enter ARDS. What happens is what we talked about, right? When we have that inflammatory response, what happens? We have the leaky capillaries, right? Fluid leaks out into our extravascular space. When we're talking about pulmonary, our fluid is leaking into our lungs. It's leaking into our alveoli, where gas exchange occurs. It's weighing down our alveoli. We're going to have huge puffy infiltrates, consolidations. Patient's going to be severely shortness of breath, tachypnic. They're going to be in a respiratory failure, severely hypoxic. This patient's going to need mechanical ventilation for sure. And we're going to talk about this in full detail once we do get to ARDS. Endocrine problems, they can develop hyperglycemia, hypoglycemia. We can end up, again, we talked about in hepatic encephalopathy. Once our liver gets affected by decreased perfusion, we're going to have increased liver enzymes. The patient may become jaundice, decrease in albumin levels, coagulopathies, meaning that the patient's going to enter what? DIC, disseminated intravascular coagulation. We've talked about all of this, and that's why I don't really want to get too much far into MODS, because we've really mentioned a lot of this already. I know this is a lot of redundancy, but renal, we're going to have that decreased urine output, okay? The patient may be anuric, totally, they can lose total urine output. We're going to have an increase in BUN and creatinine due to the decreased perfusion. We may see a decrease in urine osmolality, increase in urine sodium. Patients actually may need dialysis. A lot of patients who are in a severe shocky state and their kidneys are not getting better on their own and they're not getting that perfusion back, we need to work for them and provide them with dialysis. GI, we know our gut's slowing down. We're having a paralytic ileus. So that means we're going to end up with some necrosis in our gut. We're going to have ulcerations, GI bleeding. That's why these patients, that are in any type of shock may need an antacid. They may need a proton pump inhibitor, so they may need to be on some protonics. But we always need to be keeping constant monitor of bowel sounds, monitoring them for distension. And hematologic, monitoring bleeding, especially when our liver becomes hypoperfused, right? So observe for bleeding from any, oozing from IV sites, rectal bleeding, blood in the urine, obvious sites of bleeding. We need to replace clotting factors, right? We talked about fresh frozen plasma to help with that. We talked about platelets. So the more systems that are involved and that are failing due to decreased perfusion, most likely the higher our mortality rate is, right? Once patients enter MODS and we have, say, our kidneys are affected in our brain, right? Our mortality rate increases at least 40 to 60%. We can most certainly have more than 2 systems affected, and a lot of times with shock they are. So they're already in a MODS, they're already in typically a multi-organ dysfunction with any type of shock going on. In DIC, I've already talked about what I want you to know, okay? We have hypoperfused liver. Our liver becomes ischemic. So what happens is we have serious bleeding and thrombotic issues. We have accelerated clotting and abnormal response to clotting cascade. And what happens is we bleed out, okay? And again, this happens in the later stages of shock. Yes, we can transfuse this patient, but we need to correct the underlying cause and hopefully find perfusion back to our liver and hopefully correct the coagulopathies, giving them the fresh frozen plasma, giving them platelets, transfusing packed red blood cells so the patient doesn't get hypovolemic from the blood loss. So always correcting the cause. And that's as far as I want you to get with DIC. And we are done. I hope this was a very helpful voiceover. I love this content. I enjoy this content. Please email me with any questions that you have. I'll be on high alert for questions. And thank you for joining me along the ride in shock.